fracture.
Okay. Good evening, everybody.
Sir, just a minute. After my count.
Okay.
5, 4, 3, 2, 1. We are live.
Good evening, everybody. It's indeed a great pleasure for me to welcome all of you for the last day of the SKICON, which is the first virtual annual meeting of the Society of Knee Surgeons of India. So on behalf of our president, Dr. Ashok Rajgopal, our founder members, I welcome all of you for SKICON 2020. Good evening, everybody. Society of Knee Surgeons of India, known as SKI, has been a new society. It was founded in June 2019, where 26 like-minded people met together and started this society. We have our president, Dr. Ashok Rajgopal, Sachin Tapaswi, our secretary. I am the joint secretary, Parag Sincheti. Raju Ishwaran is our treasurer. Ashok Sham and Dinsha Pardiwala are our research chairs. We also have Ashish Sharma, Adarsh Reddy, Alankar Ramteki, Bhushan Sabnis, Clement Joseph, Deepak Goyal, IPS Oberoi, Jacob Varghese, Kanchan Bhattacharya, Mandeep Dhillon, and also Mohit Bhandari from MacMaster, who's our founder member, Mukesh Latta, Pankaj Walecha, Pushpendra Bajaj, Raja Bhaskar, Sharan Patil, Vijay Bose, Vijay Shetty, Vikas Khanduja from UK, and Vikash Kapoor. So all of us met and founded this society, which is having its first virtual meeting. It also gives me a great pleasure to welcome our foreign faculty. You know, all of them have been on this platform before, but for the first time today, we are having David Praker from Australia, who's going to give the ski oration. And thanks, Professor Praker, for staying up so late. I know it's past 11:30, but we appreciate you being there. And also we have Fabio Catani, the other vice presidents, Dr. Willem Murray, Manuel Mosquera, Michael Kelly, Andrew Price, and our own Dr. Ashok Rajgopal, who's present with us. Today is a very interesting day, and we have kept it as an open platform, which means that in addition to the 240 plus registrations, which we had paid registrations, today we are having it screened through OrthoTV, and we've kept it free so that we have more access and more people can see today's proceedings. So I'm expecting more than 3,000 people to view the proceedings in the next 3 hours. So this is the program. We have the ski oration today, the plenary talk, the presidential roundtable meeting, the presidential oration, and also we have a book launch by Dr. Deepak Goyal. Before I go any further, I wish to request our president, Professor Ashok Rajgopal from New Delhi, to please say a few words.
Thank you, Parag, and welcome to all our international faculty and our national faculty and all the participants. It's indeed a great pleasure and a privilege to welcome you to this SKICON 2020. Today is actually the last day of this 4-day meeting. We've had a very engaging first 3 days on the 5th and 6th of this month. And those dates were dedicated to arthroplasty and arthroscopy. And we had a wonderful session yesterday on biologics and osteotomies and joint preservation. And today is really the open platform and talks by very eminent speakers like Dr. David Praker, the roundtable with the presidents of the various knee societies. And I would like to welcome each and every one of you. And we hope you have a wonderful next 3.5 hours of deliberations. And we look forward to you joining SKI and further deliberations. Thank you, Parag.
Thank you, Professor Rajgopal. I would now like to introduce the anchor for today, who is our own treasurer of SKI, Dr. Raju Ishwaran from New Delhi. He is working at the Meenakshi Orthopaedics and Sports Medicine Clinic, and also is attached as a consultant sports medicine surgeon at the Max Healthcare Hospital in Delhi. He is essentially an arthroscopy and a sports medicine specialist and has over 15 years experience in this field. He's very academically oriented, has many papers published in peer-reviewed journals, has been trained and done fellowships nationally as well as internationally. I wish to welcome Dr. Raju Ishwaran and hand him over the further proceedings for the day. Over to Dr. Raju Ishwaran.
Thank you so much, Dr. Parag. I'll just start sharing my screen. So if the proceedings of the day were to be summarized in one quote, it would be this. It is a very interesting day in which we have a lot of very eminent speakers who would share their life's experiences with you, both in the forms of technical and roundtable discussions, panel discussions, and I would advise everybody to pay due attention to their deliberations. You already heard about the layout of the program. And I'll go straight ahead and introduce the first speaker of the day, the first key oration to be given by Professor Dr. David Praker. He's an associate professor and orthopedic surgeon at the North Shore Knee Clinic and a visiting medical officer at the Royal North Shore Hospital. He trained in his basic medical education and orthopedics in Sydney, and then he went to London, Ontario to do his fellowships in joint replacement and sports medicine, where he was trained by none other than Dr. Fowler Kennedy. He is the co-founder of the Sydney Orthopaedic Research Institute, which started in 2002, and this institute has generated a lot of interesting research. He is a consultant knee surgeon to various domestic and international sports teams like the Greater Western Sydney Giants, West Tigers, Canterbury Bulldogs, and very interestingly, the Manly Rugby Football Club. He's the immediate past president of APCAS from 2017 to 2019. Presently, he's the second vice president of ISACOS, and I think he's likely to take over the presidentship at the Boston meet in 2023. And he's also the board member of the ACL study group. Dr. David Praker is no stranger to India. He has traveled extensively within the country during various meetings, like the Pune Knee Course, for example, and he has been kind enough to mentor several young Indian orthopedic surgeons with his clinical skills at various conferences. He is very heavily into research. He has published over 20 studies in prestigious orthopedic journals and has an extensive research portfolio. And if you look at the Sydney Orthopaedic Research Institute website, you would find several very interesting papers which are published by their group in this year only, like these. And he was also a part of a very high-powered Delphi panel. And Dr. Praker, you'd be very happy to know that 4 of our SKI members did something similar for the Indian Journal of Orthopaedics quite recently. So without further ado, I hand over the screen to Dr. David Praker. And as you heard Dr. Parag mention, it is 11:30 p.m. in Sydney right now. So Dr. Praker quite literally is burning the midnight oil for us. Thank you very much indeed for your presence in this meeting.
Thank you very much for that very extensive and very kind and very generous introduction. I'm just going to share my screen. Can everybody see that?
Yeah, it is visible.
Okay, so thank you again for that very kind introduction, and great congratulations to you all on starting this exciting new society. I'm sure it's going to go on to become bigger and a big influence on knee surgery in India and around the world. These are my declarations. So thank you to the Indian Knee Society and all of my Indian friends and colleagues, particularly Parag and Sachin, who have been friends for a long time. As mentioned, I came to India in 2016 and traveled around, had a wonderful experience, and finished in the meeting in Pune. And we also have a strong relationship through all of the fellows that we've had over the last 10 years or so. And it really makes me happy to hear about them going on and doing wonderful things and becoming excellent surgeons when they get back home. So I just thought I'd start with a few philosophical thoughts. When we talk about knee preservation, and when the title of this talk was given to me, I thought about it. And usually when we talk about knee preservation, we're talking about surgical alternatives to arthroplasty as surgeons. But if we look at the meaning of preservation, it really means the act or process of keeping something in its original state or to protect it from being damaged or destroyed. So if we're preserving knee structure and function, we're really trying to prevent damage by injury prevention or taking measures to slow the progression of the damage. So a lot of the procedures that we talk about under knee preservation, like osteotomy or meniscal allograft or condyle resurfacing or stem cells, for a lot of these procedures, the damage is already done, and they're often more salvage procedures rather than joint preserving. So I think more accurately, what we're talking about is trying to restore knee structure and or function. And when I think about it, very few surgical procedures that we do literally preserve the joint. I think repairing a bucket handle tear of a lateral meniscus does. It takes a knee from being potentially very badly damaged to becoming normal again. And maybe osteotomy in very early stages of joint degeneration or cartilage transplant for acute cartilage injury in an otherwise healthy knee. But even ACL reconstruction, it restores stability. We do a good job with that, but we still don't have evidence that we prevent osteoarthritis. So I think in my language, knee preservation basically means maintaining or restoring knee structure and function without resorting to arthroplasty. So we should be looking at things that avoid damage by preventing injury. We should acutely manage injury to restore structure and prevent ongoing damage. We need to have ongoing management to avoid any progressive damage. And our surgical interventions should be trying to alter the natural history of the condition and stop or slow progression of damage. So with that introduction, I think the critical areas of knee preservation are injury prevention
and drug supplements,
managing the early stages of arthritis, often non-surgically, preserving meniscus tissue, making joints stable, restoring cartilage as much as we can, and osteotomy to realign the joint. And I don't have time to cover all of these areas, so I'm going to focus on things that I think are particularly important: injury prevention, meniscal preservation, and osteotomy to realign the joint and slow the progression of arthritis. So if I start with injury prevention, we should all be familiar with the injury prevention programs that exist that have been shown in a lot of evidence to prevent primary injury. And although we like treating injuries as surgeons, we have a responsibility to the athletes that we look after to make these programs known throughout the community to try and prevent injuries. We've done a lot of research around re-injury after ACL reconstruction. And ACL re-injury really is devastating for athletes. It's costly, it's psychologically damaging, and in some studies, up to 20% of younger patients will have a re-injury after they've had their initial procedure. So we developed a program to try and improve the safety of returning to sport. We did a literature review looking at things that predict success in getting back to sport and things that predict the risk of re-injury. So we developed a program that involves clinical measurements, PROMs, functional testing, and this developed a valid, meaningful, practical tool for assessing whether patients are safe and ready to return to sport to reduce their chance of re-injury. And we tried to make it easy and presentable for patients and their treating therapists by having a traffic light system. So we measure limb symmetry, and if someone has a green light, that means they're symmetrical with their contralateral leg. Amber light means they're close, but red means they're not quite ready. So if we look at this patient who's had their testing done 9 months after ACL reconstruction, we can see that everything is green. They've passed everything. They're ready to go back to training and then back gradually to competition. This patient at exactly the same time frame has a lot of reds. They have weakness in their muscle strength. They have poor balance. They have poor agility, and they need to work on these deficits before they go back to sport. And if we look at 400 of our patients, then more than half have some deficit. So clinically assessing patients is really not enough, and you need to delve a little bit deeper into their recovery and their rehabilitation. So routine return to sport testing is really an important component of any rehab program after ACL reconstruction. We do it at 6 and 9 months. We've shown that the majority of patients, even though clinically they look well, have not achieved limb symmetry by 9 months. So I'd really encourage everybody to test your patients properly before you let them return to competitive sports. And just one final thing on reducing re-injury, just from the surgical side, we've done a lot of research around the lateral-sided procedures that we do in addition to ACL reconstruction. We've published 2 papers this year in the Journal of Isocos looking at lateral tenodesis and anterolateral ligament reconstruction. So this was a cadaver model, and this is because this technique has become very popular recently to try and reduce re-injury. And we tested about 6 different types of reconstructions, and I won't go through all of them in detail, but the summary was that these procedures do add additional control of rotation beyond simple ACL reconstruction. They do cause increased lateral pressure in the lateral compartment, particularly with the tenodesis procedures, so we need to be cautious about how we tension these grafts. In my practice, I use these for revision procedures, and more commonly recently, I'm using them in high-risk primary procedures, particularly in younger athletes and higher-level sports, patients with ligamentous laxity, and patients with increased tibial slope. And there is developing evidence that this procedure does help reduce the re-rupture rate in these high-risk individuals. So I'd like to move on to meniscal preservation now. And I think the consequences of meniscal loss are very well documented, particularly in the lateral compartment. And if we look here, you can see in the medial compartment, even without the meniscus, the joint is quite congruent. Whereas on the lateral, once you take out the meniscus, you have two convex surfaces, and it's very unforgiving with a lateral meniscectomy. And long-term results that have been previously published 30 years after total meniscectomy in adolescents actually show quite good results with medial meniscectomy, but quite poor results after lateral meniscectomy. So we really need to try in particular to preserve the lateral meniscus. And I think saving a meniscus is one of the most valuable things that an orthopedic surgeon can do, particularly the lateral meniscus. And if you look at young patients like this one, 25-year-old athlete, and they're starting to develop wear here, and when we look at their arthroscopic picture, this is a very difficult situation, and we really don't have anything that we can do to reverse this situation and to make things back to normal. We just have to try and manage it for the athlete. It's also critical to recognize which menisci actually can be saved. Repairable versus potential to heal need to be distinguished, and we don't want to put someone through a lengthy meniscal repair and rehabilitation period if it's not going to work. And we can repair any meniscus, but we have to make very critical and important decisions about whether the meniscus has a chance to heal. So if we look at this meniscus, for example, it looks reasonably healthy, but the tear is white on white. It's a stable knee. It's a middle-aged patient, and we can repair that. We have to think very carefully as to whether we think it will heal. And we may be more aggressive in younger patients and less so in the older patients. So meniscal preservation is well established that lateral meniscus repair of a bucket handle tear is very successful, and really these should always be repaired. They should never be removed. With the medial meniscus repair of a bucket handle tear, if it's a stable knee, then most of the literature would suggest these have worse outcomes, probably because the meniscus itself is not particularly good quality. But in the presence of an ACL reconstruction, repair has much better outcomes, so we can be more aggressive in that scenario. And newer techniques have come to light over the last 5 to 10 years with meniscus root repair, repairing radial tears and ramp lesions. Meniscal allograft is something that I do occasionally, and it does have good outcomes, but at this stage, we don't really have good evidence that it actually preserves the joint. So it gives patients improvements, but not chondroprotection. If I go through some examples here, so this is a 19-year-old with a medial meniscus bucket handle tear. We can see the large fragment here, and this is a young person. We want to try and preserve it. We raft the area. You can see that that's a fairly vascular part of the lesion. We use this meniscal rasp. Then we do inside-out suturing in the body part of the meniscus, and then all inside as we get more posterior. And in a young patient, in a red-on-red or a red-on-white zone, it has a good potential to heal. If we look at lateral meniscus repair, these patients usually present with a locked knee, with an MRI scan showing the two triangles together with a displaced posterior horn. Occasionally you'll get patients presenting with a history of locking, but the knee isn't currently locked, and the MRI scan may actually be normal. So if you get patients with recurrent locking and lateral-sided pain, then be suspicious that their meniscus may be unstable. And the repair of these is usually pretty straightforward. It's usually an all-inside technique, as the majority of the tear is around the posterior horn. So again, a 19-year-old male, intact ACL, we use the rasp to promote healing around the region of the tear. And there's usually one suture placed anterior to the popliteal hiatus, and then 3 or 4 sutures around the posterior horn region. And we can usually get a good stable repair, and this is very successful. It's very rare to see one of these fail. This is microfracturing in the notch to bring in some blood and improve the healing around the meniscus tear. So root tears, which ones should be repaired? So if you see a root tear in association with an ACL rupture, these should always be repaired to preserve the lateral compartment and improve the stability of the joint. With the medial meniscus, the ones that have the best chance of working, if they have an acute history of trauma, if they have normal alignment, they have no arthritis, they're not overweight, the tissue is healthy, and this is mostly in younger patients who have had a specific injury. If we have older patients like this one who has arthritis, bone edema, a degenerative meniscus, you can repair it, but it's unlikely to heal. And so these ones usually need more non-surgical treatment. So this again is a young female with a traumatic medial meniscus root tear. You can see the absent meniscus on the sagittal and the tear on the coronal image. And then if we see the repair, there is the avulsed meniscus. We prepare the bed, we pass a guide wire up, and we put usually 2 or 3 locking sutures in the root of the meniscus and then bring them down into the bone tunnel. It's a fairly straightforward procedure, and it usually has good outcomes. And that literally will help preserve this joint that is otherwise normal. Radial tears. So when we see traumatic radial tears of the lateral meniscus in younger patients, particularly this one here, you can see this tear goes right out to the very rim of the meniscus. It separates the fragments. That has completely defunctioned that meniscus. That is the same as a complete meniscectomy. We sometimes see them in association with ACL injuries. And in these ones, I think it's important to try and repair at least the periphery where there is some vascularity and debride the inner rim. And doing so, you restore some continuity of the rim and some meniscal function. And I think it does have a big positive impact on the natural history of the condition and does help preserve the joint. If it's more anterior, like this one, outside-in techniques tend to work. If it's more on the body, all inside or inside out. So this patient here is like a 19-year-old male. Has had a valgus injury. You can see the absent meniscus here and the radial tear there, the radial tear here. And if we look at the arthroscopic image, you can see the tear going right out to the periphery of the meniscus. The inner part is avascular, and as we get more to the periphery, you can see some vascularity there. That's the area that has a potential to heal. So we'll debride the inner part to establish a smooth contour and get rid of the avascular part. And then we can put sutures that transversely go across the tear to bring the tear together. This usually works reasonably well. And you can see here I've put one anterior, one posterior to the meniscus. And we can watch as we tension those sutures and bring the meniscus together. And these tears obviously need to be rehabilitated quite slowly to give them a chance to heal. And once we've done that, then I think it does improve the prognosis. You can see there's 3 tears across that three sutures across that meniscus tear. It's quite nicely reduced there now. Ramp lesions have become very well recognized over the last 5 to 10 years in conjunction with ACL injuries. And we can usually see them on the MRI scan, but sometimes you can't. Sometimes you just have to be suspicious that they may be there. If you just do a standard arthroscopic view, often it's easy to miss these. So it's very important that you put your arthroscope through the posterior, through the intercondylar notch into the posteromedial space. So if we look at this person, the meniscus doesn't look too bad from the front. If we go through the notch, we can see that very large rent between the meniscus and the capsule. Again, we can abrade the area, and I will usually repair these with an all-inside technique. I think it's quite straightforward to do it that way. People do describe doing it through a posteromedial portal. But I think if you can get good visualization, you can usually repair it with an all-inside technique, and it's usually quite straightforward to do so. So these are really important to look for. Every time you do an ACL reconstruction, put your scope out into that posteromedial space and look for this tear. You'll find it at least 20% of the time. Meniscal allograft, it's quite hard to get this tissue in Australia, but we can get it. But for me, this is a procedure that I do probably 4 or 5 times a year. The indications are for symptomatic meniscal deficiency. They need to have favorable alignment, or if not, then we correct it with an osteotomy. A stable joint, no stiffness, ideally early chondral wear, and they usually give good outcomes, but they're not normal. So in conclusion, it's very important to recognize the tear pattern, assess the potential to heal, be more aggressive in younger patients, ACL reconstruction and lateral meniscus. We did this study, systematic review, showing we get better results in ACL reconstruction patients, less complex tears. And if you're going to take these on, you really need to know all of these techniques and be able to use them. So finally, I'd like to talk about osteotomy. So achieving the optimal outcome with osteotomy is something we've done a lot of work on. And to do this, we need appropriate patient selection, clear goals. It needs to be safe, easy, accurate, and reproducible, and allow an accelerated recovery and give predictable outcomes. So who should have an osteotomy? Well, we commonly do it for arthritic change in younger or more active patients. Patients have meniscal deficiency, or we're treating chondral pathology. Patients have instability. So if someone has a big varus deformity, a lateral thrust, and postlateral insufficiency, if you want to reconstruct it, you need to correct their bony alignment as well. An occasionally less common case like this young girl with quite marked tibia vera with medial compartment stress fractures. and we corrected her to neutral, and that corrected the problem for her. So many indications for osteotomy, most commonly osteoarthritis. And to get better outcomes, we seem to get better outcomes in most of the studies with younger patients, patients who aren't overweight, whose joint is not stiff and not severely arthritic. So this does give an argument for earlier intervention. And we've published on this ourselves, and certainly we've found that patients who are overweight and whose joints are very stiff have more severe arthritis, more severe deformity. You can get a good outcome, but it tends not to last as long and be not quite as good as in the earlier disease. So the ideal patient is someone who has well-localized pathology and symptoms, minimal stiffness, they're a healthy weight. We don't do this procedure on smokers, and the patients need to have appropriate expectations. They can be improved but not made back to normal. They should get survival beyond 10 years, and it shouldn't compromise their knee replacement. If we look at the evidence base that we have personally, we've looked at a series of over 200 patients, predominantly male, about average age almost 50, and the average correction is about 8 degrees. And across the Q score, we get improvements in all of these domains, but it's interesting if we then compare them to age-matched norms, which is the gray bar here, you can see although we get improvements, we don't get patients back completely to normal. So it's important to explain this to patients. They can get an improvement, but not usually back to normal. Our survival is almost 100% at 5 years, but at 10 years, it drops to 80%. I think if we exclude those patients I mentioned before with stiff joints and severe arthritis, and you select your patients well, you should be able to get survival beyond 90% at 10 years. What alignment should we aim for? Well, traditionally we talk about overcorrection. Coventry always talked about 5 degrees of mechanical valgus, and more recently people talk about the Fujisawa point, which equates to about 2.5 degrees of mechanical valgus. Our goals are to achieve the adequate mechanical effect without compromising someone's function, and we want to reduce the load on the affected compartment. We need to relieve pain, allow cartilage recovery, and avoid a recurrent deformity. So we did some simulation of this with our engineers and showed that as you increase the valgus, you decrease the load on the medial compartment, and the loads between the two compartments on this simulation were equalized at 1.5 degrees of mechanical valgus. That gives us some indication. We've done gait analysis, so the preoperative adduction moment, which is the load on the medial compartment, when we correct people to 2 to 3 degrees of mechanical valgus via navigation, then we eliminate that adduction moment. We've also done studies looking at recovery of articular cartilage. Again, when we convert people to about 2.5 degrees of mechanical valgus, we show cartilage recovery over a period of about 2 years. So that seems to be about the right amount to correct people when they have advanced arthritis. So for arthritis, we'll correct to 2 to 3 degrees of mechanical valgus. But if someone has more early arthritis or it's chondral lesions, meniscal deficiency, we'll correct them to just 1 or 2 degrees. If they have correction for instability with a reconstruction, neutral alignment, and if they have lateral compartment arthritis, again, we correct them to neutral or very slight varus, so individualized depending on the pathology. How do we achieve that? Well, preoperative planning is actually quite accurate and quite good at predicting the wedge size, but it does have some limitations. They're not dynamic films, and when we do things surgically, we don't have the ability to simulate weight bearing. So that's why we turn to computer-assisted surgery, and we've used computer navigation to do osteotomies around the knee for about the last 15 years and been very happy with it and its accuracy. We've done studies previously correlating it to post-operative alignment X-rays and showed that it is very accurate in achieving what we want to achieve. More recently, we've turned to 3D printing using customized guides with an image-based 3D printing. And we use these in conjunction with computer navigation now, but as we show that they're more accurate, then we may even take the place of computer navigation. When we plan for osteotomy, we do an EOS scan. I don't know if you have these in India, but this is a long leg scan in 2 planes, which allows us to look at the overall alignment and the articular angles and the tibial slope. We do gait analysis on the majority of our patients. We do a 3D preoperative CT scan so we can look at the deformity in each bone, determine where we want to do osteotomy, and we have an app where we can dial in the amount of correction to work out the actual wedge size and the final alignment. We do a 3D scan of the tibia so we can work out the exact shape that we're going to create with our wedge and plan the size and the angular correction. We can then plan the position of the plate and use this to produce a 3D printed guide that allows the cut for the osteotomy and the screw holes. And we can translate this into the surgical procedure. You can see here we've got the 3D guide as well as the computer navigation, and then hopefully achieve a good outcome. We've also done some bilateral simultaneous osteotomies in more recent years, and this is a good procedure as long as you have a good patient who's willing to have a relatively slow recovery in the first 6 to 8 weeks. In terms of supplementary treatments with osteotomy, we've done a study previously where we added autologous chondrocyte implantation to osteotomy, and we're able to compare this to osteotomy alone. And when we looked at the two groups, they were quite well matched. And as you know, you do an initial arthroscopy, harvest the chondrocytes, and then come back 6 weeks later to reimplant them in conjunction with the osteotomy. And we did have some cases, like you look at this case here, where there's no articular cartilage there. They get good improvement in their scores, and they get good articular cartilage refill there. And you can see that again here. We have other cases where they get moderate refill, and you can see again here, this looks like quite good refill, but it's not normal cartilage. And then we get other cases where we get absolutely no cartilage regrowth. So quite variable results. And we concluded that it does give some benefit for some patients, but it was quite expensive. And we came to the conclusion that it couldn't be recommended as routine practice. So currently what I do with my osteotomies is I microfracture any bare bone. And recently we've started using some stem cells. So this is a 43-year-old ex-Olympic skier, had an osteotomy, and we did some stem cells injection just with the procedure. That's her preoperative MRI scan, and that's the post-operative. So this is just very small numbers that we've started with, but it looks reasonably promising, and we'll continue those studies. So in conclusion, the ideal osteotomy has to have careful patient selection, a refined preoperative analysis, more precise individualized correction, improved supplementary techniques, and accelerated rehab. And if I have time, I'll just go through a few case examples just to illustrate how we do this. This is a 42-year-old female, had a post-traumatic deformity. This is after a motorbike accident about 20 years earlier. You can see she's got major deformity in her knee joint. She's got a valgus deformity in her femur from previous surgery and marked joint subluxation. So we planned a closing wedge osteotomy on the femur with a 3D printed guide to make her femur straight again. And then we planned an opening wedge osteotomy on the tibia. And you can see here that in the coronal plane, we needed a 20-degree correction, and the sagittal plane a 20-degree correction. And this allows us to plan the correction we're going to do, make some 3D printed guides, and then execute the osteotomy. And this is what she looked like prior to the surgery. This is after the surgery. And these are her x-rays. And this is her overall alignment. So she's never going to have a normal knee, but she's a lot better now. And this will hopefully get her another 5, 10, 15 years before she has to have a knee replacement. The second patient, someone had an osteoid osteoma excised, and unfortunately, after it was excised and bone grafted, went on to subchondral collapse. So we made a 3D printed guide that allowed us to excise that area from the tibia and excise a corresponding area from an allograft to insert into that area, and also to do an osteotomy. So this was done all in the one stage. An osteotomy offloaded to 3 degrees of valgus, and it followed that patient's also doing quite well. This is a patient who is 31 years old, previous lateral meniscectomy, developing articular cartilage wear here and valgus alignment. If you look here, you can see the valgus is actually in the tibia. So in those cases, I like to do the correction on the tibial side with a closing wedge osteotomy that you can see we planned out here. And this is the final result. And we did a meniscal allograft at the same time. So again, hopefully this will help preserve her knee joint for a longer time into the future. And the final case is a 16-year-old boy who had diaphyseal aclasis. He had 2 previous ACL reconstructions and a recurrent instability. And if you look at his alignment, he's in significant valgus, a lot of which is in the tibia. He's got a failed ACL reconstruction. His alignment on navigation was 8.5 degrees of valgus, and we did a medial closing wedge osteotomy and revised his ACL reconstruction and take them into 1 degree of varus. So in conclusion, preserving the knee joint is multifactorial. Different interventions are required for different stages. Surgeons need to understand the natural history of the condition. They need to understand the evidence base for their interventions. Timely application of important strategies are very important, including injury prevention, non-surgical treatment of arthritis, meniscus repair, cartilage repair and restoration, joint stabilization and realignment surgery. And on that note, I'd like to thank you all for your attention, for your invitation. I'd like to also wish you all the best for the upcoming test series between India and Australia. I'd like to invite you all to join us in Cape Town next year, we hope, for SKICON. Thank you again.
That was an excellent talk, Dr. Parker. And the key messages for me, at least, were to not to delude us into thinking that ACL reconstruction is equal to joint preservation, and to do a very careful patient selection for osteotomy, especially the patient-specific instrumentation and navigation, look quite exciting indeed. I open this ski oration to one or two questions. Dr. Parag, would you like to start off by asking?
Yeah, so typically Oration doesn't have questions, but we should have one or two questions. But one of my questions is, Professor Parker, I know you do a lot of osteotomies and you do a lot of unicondylas also. So in the recent past, have your indications for high tibial osteotomy gone down? And are you doing more of unicondylar knees? Is that what you do? Because I've seen that as a trend all across.
Well, it's actually quite the opposite for us. And I think I'm much more selective with unicompartmental replacement, because to me, that is still a joint replacement. And so those patients have to have, they're usually older patients. They have absolutely perfect other compartments of their knee. Whereas when you're doing an osteotomy, we're trying to preserve the joint in younger patients, so we bend the rules a bit more. And I think if we look at countries that have a joint registry, like Australia, then we know that the failure rate of unicompartmental procedures is a lot higher than total knee replacements. And in those countries, the utilization of unicompartmental has gone down quite a lot. So for me, I do about 300 knee replacements a year, about 5% are unis, but I'm much more aggressive with osteotomies in younger patients to try and preserve the joint.
Quick last question. So what is your take on orthobiologics? Do you use a lot of PRP, HA, or steroids? A quick answer.
Sure. So I don't use steroids. I maybe for an inflammatory arthritis, but I think steroids are very transient. I think they've been shown to damage the joint if you use them repeatedly. There is good evidence in mild to moderate arthritis for PRP and slightly better evidence than HA. We use both. We do a lot of PRP. We have a non-surgical clinic we've set up here, and one of the main things we do is leukocyte core PRP for mild to moderate arthritis.
Perfect.
Right. So I'd like to thank on behalf of SKI, Dr. David Praker, for your excellent oration. And we hope to take key inspiring messages from your talk and continue this journey of joint preservation and research that you've so nicely inspired us to do. Thank you very much indeed. And
thank you very much. Thank you for the invitation. Enjoy the rest of the meeting.
Thank you. Thank you.
So it gives me a great pleasure to introduce the next speaker, who is one of our own founding members, Dr. Vikas Khanduja. He is a consultant orthopedic surgeon at Addenbrooke's Cambridge University Hospital, NHS Trust. He is the associate editor of BJJ, formerly JBJS, very high impact journal, in fact, perhaps the highest impact journal that most orthopedic surgeons read. And he is academically very active, apart from being the vice president of the British Hip Society. We all know his seminal work in the field of hip arthroscopy. And he's authored several peer-reviewed articles and books. So over to you, Dr. Vikas, and he will be speaking to us on a topic which is the very core of our organization. Why SKI? What are the ideal aims and objectives of a society like SKI? And after finishing his talk, he will take over along with Dr. Mohit Bhandari, the President's Roundtable discussion. Dr. Vikas, the screen is all yours.
Thank you very much, Raju, for the kind introduction. And just confirming that my screen is visible.
It is not as yet visible.
Okay. Let's just quickly go.
Perfect. So we can see your screen. Wonderful. Please go ahead, Dr. Vikas.
Okay. Thank you very much, Ashok, founders of SKI, for allowing me to talk on this. It's actually been a great talk to prepare because it's given me some time to reflect not only about SKI, but other organizations that I'm a part of as well. So let's dwell into why SKI and need and objectives, or for that matter, any society. So the way I would like to cover this is just talk a bit about the paradigm shift in thinking and give you an example of what has made a huge impact on my thinking. Dissect the aims of SKI, talk a bit about research and education and my thoughts on it. The survey that we circulated around in the founder members of SKI, that results. And then finally, I'll come to why an organization like SKI is required. So I take this example. This gentleman certainly has had a huge impact on my thinking, and probably it will resonate with most of you in India as well. This gentleman single-handedly possibly changed the way healthcare in terms of eye care is delivered in India. Now, essentially, if you listen to, or if you read his books, and if you listen to the people who talk about him, I unfortunately didn't have the opportunity to listen to him directly, but they talk about the fact that at one stage in his life, when he was a surgeon, he was focused on getting the retina absolutely perfect. And all of the measures that he took in his surgical expertise were to get the retina right. Now that philosophy changed completely when he started thinking about addressing a different problem, and that is blindness in India. So it really took that paradigm shift of thinking from the retina of a single patient to the problem of a whole country that actually brought about a complete change in eye care in India. And that's what's possibly required for societies like SKI and other societies around the world as well. You need a paradigm shift in thinking of what exactly are you trying to solve? What are the problems? Now, with that in mind, let's look at the aims of SKI, which are there on the website, and the founder members have taken great pains to actually produce these aims. And essentially, they boil down to the pillars of research and education. Now, let's look at both of them in detail, and I'll probably put in some of my thoughts into this, and then we can dwell on it as well later. So research. Now, if you look at it globally, a huge amount of research, or a huge amount of money is actually dedicated to research, be it the US, where the NIH invests over 30.9 billion actually in research, in the UK itself, Canada, Australia, all these places are spending a huge amount of money on research because it is a necessity. If you look at the corporate sector, right from Roche to Johnson & Johnson, again, budgets in billions are dedicated to research, again, because it is a necessity. And if you look at India itself, your own country, then India's 5-year plans certainly have a huge amount of money escalated for research, and the ICMR gets a huge amount of money from the central government to actually facilitate that, which is possibly where SKI should be tapping into for resources. The strengths of a country like India are in numbers. So the numbers of operations going on are phenomenal. Poverty is phenomenal, so possibly it allows you to look at different models of healthcare. The pathology is extremely varied and interesting. The huge amount of talent pool in terms of surgeons and the IT boom and the infrastructure in IT that exists, that needs to be harnessed and tapped on as well. So those are the strengths. And with those strengths in mind, let's look at these. So I tried to find out how many orthopedic surgeons are there in India. I could not get a clear answer, possibly about 30,000. How many of them are actually performing knee surgery? No answer. How many orthopedic residents are there in the country? We got some answers, probably about 3,500, but we do not know how many of them are actually interested in knee surgery. So the first thing to be tackled is really, or could be tackled, is the provider status. The next thing is, what is the scale of the problem? What is the prevalence or incidence of things like osteoarthritis in the country, ACL injuries, multi-ligament injuries, meniscal injuries? What exactly is happening? What are the numbers? What is happening in the knee-related trauma? Again, the incidence and prevalence of that. what kind of implants are being used and which implants are being used. Most importantly, what are the revisions and complication rates? Because only when you know the revisions and the complication rates could you actually devise programs to reduce these. And how do you make it much more cost efficient, which I think is the key for a developing country. So the scale of the problem needs to be well defined and known. And that's where SKI should be coming in. And finally, it's about the end user. What do the knee surgeons actually want? The surgeons who are actually part of SKI or otherwise. So therefore, a survey needs to be done for those members of SKI and beyond who are doing knee surgery to find out exactly what they want. And finally, what does the public want? Do they want the best specialists nearer to them? What is the cost actually for these interventions and model of care? All these questions need to be answered. And then what are the specific needs of the population? With 3D printing coming up in a big way in India, product development specific to the needs of the Asian population is the key. So that is the other aspect where research should be focused on. So just a few thoughts about exactly how to go about it and what needs to be answered. So we need to look at the provider status. We need to look at the scale of the problem. What are the user requirements and what is the specific requirement or the need of the population? And that's what SKI should be initiating. Now let's look at training in a bit more depth. Obviously, the procedures, as you've seen over the last 3 days of the SKI Congress, are increasing in complexity significantly. And certainly the training period required to learn these procedures is going down immensely. And it's moving from an apprentice-based program to a competency-based program in most parts of the world and possibly in India as well. If you look at the problem, India alone has about 100,000 doctors registered in the Medical Council. And this is the data I got from 2014, definitely old. The population of more than 1.2 billion. So the ratio is 1:115,000 population as compared to 1:15,000 in the Western world. So there's a huge gap there. And if you look at surgery, that gap widens. So definitely there is good undergraduate medical education, extremely good postgraduate medical education, but then there's a lack of good subspecialty training, lack of nurse specialists, AHPs and multidisciplinary roles, lack of audit and research nationally, lack of clinical governance, lack of management skills for doctors, innovation, communication skills, and soft skills. So all these areas are lacking. So there's a huge skill gap in the medical and the paramedical sector as well, barring a few institutions where obviously the bar is extremely high and they're delivering everything. So one can address the problem with more number of surgeons or increase the skills and decrease the gap, which is where the National Skills Development Corporation was set up by the current Prime Minister Shri Narendra Modi. So that was the government input to this problem. And certainly that needs to be tapped specifically for knee surgery, and SKI could be coming in there as well, specifically for upgrading the skills of the surgeons and others as well to deliver knee surgery in India. So if you look at models of learning, a Fitz and Posner model of attaining procedural competency comes in, and he essentially talk about the cognitive phase of learning. So where one learns about everything in knee surgery, that's the cognitive phase. The integrative phase is where one is actually learning about the operation and learning the steps in doing that operation. And finally, it's the autonomous phase where one is actually doing the operation independently and going forward with that. So these two certainly can be delivered outside the operating theater. And that's what organizations like SKI need to be thinking of in detail. And we need to draw parallels from the airline industry, where they actually we've obviously got the WHO safety checklist from them. And we also need to think about simulation training, essentially from, again, the airline industry. So a framework for technology and enhanced learning could be set up, and this is well described in other aspects of surgery, where a novice would start off with specific task simulation, and then over a period of time and with specific tasks, you gain competency, and mastery in that specific subject. And there are enough examples of virtual reality simulation, again, for knee arthroscopy, ACL reconstruction that exists, and that need to be looked upon seriously by societies like SKI to ensure that training is delivered appropriately, both with high fidelity simulation and low fidelity simulation as well, to address the skills gap. And then finally, evaluation should be fairly formal as well. And we've got clearly defined models of evaluation by Kirkpatrick, where you start off with the reaction after designing any specific educational event. So the reaction of the trainees or the delegates with questionnaires. Then you go on to learning, the written test, the performance task, graded simulation, behavior of exactly how the behavior changes after that intervention, that is performance appraisal, and finally the results. So these need to be in place as well, proper evaluation programs following any intervention in training. So that's sharing a few thoughts on education and research and what SKI could potentially be doing in both these areas to actually impact appropriate knee surgery, skill upgradation in the country, and offering better outcomes as well. Now let's look at the survey results which we circulated around the founder members. And a big thank you to Bhaskar and Rajasekharan, who's been helpful in actually sending out the surveys and then collating the results as well. So we got everybody to respond from the founder members, and average in terms of the times of years spent in the specialty was about 14.1 years, ranging from 5 to 35. Now, our average number of societies that people are a part of was about 2, and most common societies outside SKI that they were a part of were the ISACOS and ESCA. Now, if we ask them which of the following options below that they thought needed to be the core focus of SKI over the next 2 years, collaborating in multi-center high-level research comes top, and then influencing healthcare policy comes next. So these are the 2 most important things that the founder members felt should be the core focus of SKI. The next question was, what do you think will make SKI more appealing to the general knee surgeon or orthopedic surgeon? Again, formulating guidelines on knee surgery, white papers essentially, and then invitation to be a part of a research collaborative. So those 2 come up in top. So essentially, if you look at both these questions, the 2 most important answers are research and influencing the government. The next one was, in the past 1 year, how would you rate the progress of SKI towards fulfilling the mission statements which were formulated? And it's good to see that only about 50% of them were thought that these mission statements were actually fulfilled. And so there is a lot more work that needs to be done over the next few years to actually make sure that we are delivering that. So whilst there are a number of societies, both nationally and internationally, do you need another knee society? And hopefully the last few slides have actually given you food for thought. So certainly required, but there needs to be a paradigm shift in the way of thought process of how do you deliver outcomes and what you should be doing in terms of research and training to make sure that the society is relevant. It can influence government policy and practice. It can have a reasonable impact both on surgeons and the patients, most importantly. And finally, global contribution to science as well with those studies. So definitely relevant and definitely required, but with a shift in thought process. So here are a few things which we could start off with. So in research, we've talked about defining the scale of the problem, looking at the provider themselves, what can be done, and then looking at the end user, that is the patient, and what do they want, and then basing research programs on them. In terms of training, we could look at addressing the skills gap, and we need to think of alternative methodology, not only cadaver courses and lectures like these to actually address that skill gap, but think of simulation training as well in great depth. And then for every intervention that is made, there has to be objective evaluation, potentially based on Kirkpatrick. And once we are actually writing down the objectives of each of these interventions, we need to be absolutely smart about writing these objectives. That is, they need to be specific, measurable, attainable, relevant, and time-based as well. And once we've done this, there is no doubt that SKI would be at the top of the world. Thank you very much for indulging and allowing me to share my thoughts. Thanks, Atam.
Thank you very much, Dr. Vikas. It was a very insightful talk, especially the slide on the pyramid reminded me a bit of the Maslow's pyramid. I would like to invite a quick comment from our president, Dr. Ashok Rajagopal, before you go on to the next session on what he felt about this talk and what are his views in the same direction.
Thank you, Raju. Vikas, as usual, that was a masterful presentation, very insightful, very thought-provoking. I think you touched on a lot of very sensitive topics, and I think the slide for the entire presentation was the one which was your pie chart, where the reflection of the founder members is that we need to do more, to work harder. And I think that is really the sort of crux of this whole organization. We are a young organization, as Parag has mentioned. We're only about 15 or 16 months old, out of which almost 10 months have been taken away by this pandemic. But having said that, I think the important issue is we have a lot of very intuitive minds, very good researchers, people who have their heart dedicated to the knee philosophy in all of their dimensions. And I think in the years to come, I have no doubt that this organization will grow in stature and will be a thought leader, not only in India, but certainly in the region and across the globe. And that is the paradigm that we would like to hope that we will escalate this organization towards. We have some excellent research that I'll very briefly talk about in my address. And these are really the initiation. And I think in the days, weeks, months, and years to come, I think we need to come out with a lot of white papers that will form the basis and the baseline for knee surgery in this part of the world.
Thank you very much, sir. And Vikas, are you ready to take on the next session along with Dr. Mohit? Dr. Mohit has just joined. Welcome, Dr. Mohit.
Excellent.
Thanks, Raju. Thanks, Ashok. I'll hand over to Mohit to kick off. Mohit, you're on mute, Mohit.
Sorry, I was just going to say, thank you. I was just going to say that I'll take a moment just to introduce all the speakers in this particularly important session. Now, I was just saying that while there's been many insights from the SKI meeting over the last few days, I do look with great anticipation as to what we are about to hear in the next 90 minutes or so. And I'll walk you through with my co-moderator, Dr. Vikas Kanduja, who you all know and has already been well presented, but I will take a moment also to recognize him as we go forward. But you can see this this evening for some of you and this morning for others, and good afternoon to those of you who are in Europe right now. But I mean, here are where we are: opportunities and take-home values of a knee society. You've just heard about SKI's beginnings. It's early and humble beginnings. And the question is, we are aspirational in where we'd like to go. And where else can you learn about where we can go by not getting those lessons from others who have been there before? So I think today is very much about the pearl. And as you know, I think it was quite nicely stated that it is so much about getting these pearls of wisdom. Now, knowledge is one thing, but I think most of us know that wisdom not only knows, but it also understands. And I think in this particular goal that is what we are trying to dig. And we will dig deeper. Our role as moderators will be to ask questions and hopefully stimulated discussion among a number of really keen individuals. I have the pleasure of being able to moderate with a friend and colleague. You've already heard lots about my good friend Vikas Kanduja, so I won't spend more time, but simply to say I do hope one day we will be back in Cambridge together once all of this global pandemic has been hopefully resolved. But today's stars are these 6 individuals. And I'll spend a little bit of time on each. We have 90 minutes, so please do indulge me in a little bit of thanking these individuals for spending time with us. But it is Dr. Mendes, Dr. Kitani, Dr. Vandermeer, Dr. Muscara, Dr. Price, and Dr. Raj Gopal. Dr. Kelly sends his regrets. He also wanted to be here, but we have 6 fabulous presenters. Let me just begin, if I could, briefly with Dr. Mendes. Dr. Mendes, as you can see here, and I won't go through the full list of all your accolades, but I will say that you today represent the European Society of Sports Medicine, Sports Traumatology, Knee Surgery and Arthroscopy, ESCA, a well-respected and international society. So we thank you very much for taking some time to be with us. Dr. Kitani, we also thank you for taking time to be with us, representing as president of the European Knee Society, or at least in your knowledge, that goes back at least 30 years, adult joint reconstruction, including robotic surgery. So lots to be heard from you. Professor Vandermeer, I hope I'm pronouncing this right, Doctor, because I do not want to misrepresent the appropriate pronunciation. But thank you so much for representing us today as president of ISICOS, the International Society of Arthroscopy, Knee Surgery, and Orthopaedic Sports Medicine. Also noting that we have lots and lots to learn from our friends around the world. Professor Muscara, thank you again for joining us. And I think that you may be joining us possibly via a video presentation. Regardless, we thank you for taking the time. Currently representing SLARD, or the Latin American Society of Orthopedics and Traumatology. So much appreciated for your time. Professor Andrew Price, again, professor of orthopedics in this case at Oxford, also a president of the British, or representing the presidency of the British Association for Surgery of the Knee. So we look forward to hearing from you also, Dr. Price, on where you think we're going generally, and what the importance of knee societies are. And certainly last but not least, our own esteemed professor, Dr. Raj Gopal, who will give us some closing statements, I suspect, and who's the current president of SKI, which everyone here knows is the Society for Knee Surgeons of India. Once again, I won't go into all of your illustrious accolades, but we all are of great respect to you for taking on this role and helping SKI move forward as we do. But let's begin. We have lots to talk about and lots to discuss. Let me first begin, if I can, by just introducing and asking, if I could, Professor Mendes to possibly share his screen, or if he doesn't have slides, maybe possibly consider just giving us his notation. I would say that we'd like, ideally, if possible, to have each of you present for 5 to 6 minutes. We understand if you have more to say, that's fine. We have a bit of extra time, but if you could stay roughly within those time points, that would be wonderful. Thank you again.
Ladies and gentlemen, good morning. Thank you, Mohit, for your kind introduction. Thank you to SKI for this invitation. It's a great pleasure to participate in this meeting. And it's always a great pleasure to participate in Indian meetings, because as most of you know, my very old genes are from the north of India, so I feel at home. Can you see my screen?
Yes, we can.
So I would like to start to share with you what is the importance of a scientific society. I think this mission is transversal to many others, but what was the purpose of ASCA when it was founded? What do we stand for? So the idea is to put Europe together and to bring together orthopedic surgeons, scientists and clinicians, special focus on raising the level of care to serve our patients. And this in the field of orthopedic sports medicine and degenerative joint diseases. With ASCA and with any scientific society, we have a powerful educational tool, and we can provide to members an opportunity to know exactly how they can serve better their patients. And we can also do it at a national level, in the national societies, we can do it at the international level, but we can better do it because we are independent, we are non-biased, and scientific societies doesn't have strong connections to industry. So it's really a fair tool. Regarding history, it's my honor to be among these important orthopedic knee surgeons in Europe. And when I arrived to ESCA, I would like to share this moment with you because ESCA was, I will say, not an important society. We have no office, no staff, no money. We have one desk, one lettering above the desk, and one mobile phone. And the desk was inside an accountability society where ESCA was based in Geneva. Because we are in this very difficult financial situation and almost bankrupt, we need to change the society, and we put another S. Now we have ESCA with 2 S's, and we start to work. I served ESCA in several different positions, starting in 2002, so almost 20 years. And I was ESCA president in 14. I had the luck to be there when some very important achievements of this society happened. We were able to do the foundation of the ESCA Foundation, and we did it inside one of the most prestigious foundations in Europe, the Fondation du Luxembourg. We launched the ESCA Academy, so an important tool for e-learning, completely free for our members. We were able to buy the Castor Journal. The Castor Journal at that time belonged to Springer, so we were very limited to do what we want with our journal. We launched a new journal, the Journal of Experimental Orthopedics. That is still a very nice tool of education. We opened a new office in Luxembourg. We affiliate the national societies, almost all the national important societies in Europe. And when I left it, ESCA had the best financial situation of ever, what is really an honor for me. So the structure of those societies are based on committees that work in several different specialities. And the importance of these committees and sections is that they are very spread along Europe, from the west to the eastern countries. And so we are very well covering all Europe. In these sections, people work for free. And so it's really a purpose of life. We need to like to do that because it's an important commitment and is a huge amount of work, but it's very rewarding when you like to do it. And we are now having members from 115 countries, from 5 continents, interesting 65% from Europe and 35% from outside Europe. We have 10,127 members of the ESCA communities, friends of ESCA and members of ESCA. And we have all these affiliated societies. And these relationships give us the opportunity to provide guidelines, to receive the real happening in each country, to know exactly what's happening today in Poland, in Hungary, in the difference between the culture of the north of Europe and south of Europe, to provide a new universal level of care. Also, we provide fellowship programs, giving the opportunity of all the less developed countries to have people going to the nice centers and to learn. We have 41 accredited teaching centers where people are well received. They can go to our house, they can participate in our daily life, they can see surgery, participate on surgeries. We have a very important tool on e-learning. Now more than ever, it's important. Ask Academy, with courses, with all the lectures of the congresses, videos, hands-on real-life videos. And we organize courses in all Europe, presential courses and e-learning. And also we have important publications, the books, the SK newsletter, and 2 important journals, the Castor Journal and the GEO. We have a biannual Congress. Unfortunately, the 21 Congress will be virtual because of the pandemic period. And this is the most important message that I would like to share with you, is the powerful education tool, because we combine countries, we put together people, we provide education, we have the possibility to visit, to people to visit teaching centers. And with that, we create a very important network between national societies in Europe, but also together with the very important international societies, making friends, provide medical education all over the world, and being happy with this job. Thank you very much.
Wonderful, thank you.
Thank you very much. Our next speaker for this would be Professor Catani from Italy, who's representing the European Knee Society. Fabio, would you mind loading your talk? And whilst Fabio is loading, a quick question to Jean first. So you've achieved everything in ESCA. It's looking pretty good. It's collaborating, it's providing education. Where does it go next? What do you think about the next 5 years for ESCA?
So I think now ESCA is in a very balanced and nice situation, and the people that will follow on that path will have the opportunity to bring together more people, if I'm talking about the Eastern countries. What was not achieved yet, in my opinion, was to have the possibility to give the opportunity of education on a global perspective to Russia, to Hungary, to Poland, to Serbia, and all these countries. So ESCA is working, because now I'm not involved in ESCA, I'm the treasurer of VISACOS with a great honor, but ESCA is doing it now, approaching the Eastern countries, trying to reach people, because we are able to reach the national societies, but in fact, if you reach the national societies on those countries, doesn't mean exactly that you reach people. And organizing courses and involving more and more people from the ground in the ESCA activities, I think it will be the next step for ESCA.
Thank you very much. Professor Catani, the floor is yours.
Thank you. Thank you very much. And first of all, I really thank Ashok, Rajapal, for the invitation and honor to be in this important session. So first of all, we have been initiating our work in 2014, and the statement, the mission statement of our society, as many of yours and also OSCE, is to advance knowledge of degenerative knee pathology and knee arthroplasty. And our mission statement included education and teaching, research, and professional standards. I'm underlying professional standards because it's becoming, for our society, the main topic and the main aim, also in collaboration with other society. I think that in the past, what I learned is the strong collaboration. I don't know why he's advancing. Okay. And the collaboration between the board and the members of the high quality profiling research and clinical and surgical activities. I think the main mission is the statement, but also the mission is to work together. and try to receive and also deliver the best knowledge that all the members are getting from their excellent and so really important profession. The board, as you can see here, is very important because all the people are passionate in the society, is making a lot of work in the society, as is representing all the features in terms of professions that is helping our society to fulfill the main aims and people with which in the past have been working so much. It was mentioned before, the international member is very important, is a key issue, is a 15% of the international member are really delivering to the society important answer to our questions and our work that we are doing. And so we are few with a 105, but very strong, and again is a team. COVID was the main issue in this year. And just at the beginning, the first 2 months, we developed and we made an algorithm for resuming elective knee surgery. And so we spent, guided by and led by Franco Benazzo and myself and others, trying to understand how to resume primary revision and infection in the hospitals. And so we delivered this algorithm to the national societies. And also we understood how it's important, and I will talk later on in how to organize the follow-up of the patients, because the issue now, particularly for the research, is try to follow our patients. And so we have been working in an international consensus group to publish this important paper led by Parvithi in resuming elective orthopedic surgery. So COVID-19. And so I think we need to talk about this because surgeon hospitals and patient life has been significantly changed and will change in the future. And also surgeon is alone and patient does not want to stay in the hospital and worries on rehabilitation environment, particularly for grouping. And so I think that is an issue also for the research. We need to think new rules in teaching clinical and surgical activities, and they will start in Q3, but I like the idea also to have a specific virtual and a different technology in the teaching, particularly in surgical activities. As I mentioned before, it's really difficult to follow up patients after treatment, and there is less interaction. I think this is, is disturbing and is affecting so much the research because surgeons, scientists, engineers, and physiotherapists cannot be together, and so research is highly affected. And also the travel for the fellowship programs is affecting, such as the surgeon site visit. So the key goals in education and teaching, closed and open meetings, now very poor because, we didn't do it. And so we hope to have in Q3 and Q4, 2021. We have a fantastic web seminar, online course in new technology. And this is an issue for the future as a society. And so I like to have more collaboration with the other society and try to make evidences in the application of new technology. As I mentioned before, virtual traveling fellowship, we have a core as an AKS journal, and we are continuously encouraging members to write paper, but now it's really difficult. So we need to do more work together. And as I mentioned before, the collaboration with the International Orthopedic Society is key. The World Congress has been every 2 years, a fantastic meeting, conjoint meeting between the AKS and the European Hip Society and ICJR. Gonna be virtual. research. We cannot compete with industries. And so it's important the research from the members, network of centers and members, and the definition of quality statement. This is going to be one of the major factors affecting our society. And also what we should do a lot of work is to define the algorithm on remote functional measurement, wearable sensors, and digital devices. Professional standards, I think this is the key. This is what we will learn. We are collaborating with the BASC and definition of quality statement about unicompartmental arthroplasty, patellofemoral joint arthroplasty, revision total knee arthroplasty, and also we are defining a Delphi methodology on aspirin, DVT, like a guideline on preoperative VTE prophylaxis, and also on robotic surgery. And so I would like to thank you and waiting for answers. And thank you again for for participating to this great meeting. Thank you.
Excellent, Fabio. Great talk. Thank you very much for that. While we have our next talk being loaded up by Professor William Vandermeer from South Africa, who's representing the Knee Society in South Africa. A quick question for you, Fabio. If you could kindly, just enlighten me on the virtual fellowship that you all have thought about. How are you all going to administer that, and what shape or form will that take?
We are trying to study, the teaching is not an issue, but we are creating also videos of surgical technique in the different area. And so the fellowship can be done with 5 or 6 centers that are delivering for the fellowship different topics in, for example, in osteotomies, in unicompartmental arthroplasty, but also having videos on different techniques. And so this is the only option to do it.
Thanks, Fabio. And I'm sure we'll come back to that in the discussion section. Thanks for that. William, over to you, representing SKICON from South Africa. Thanks, William.
Can you hear me?
Yes, we can hear you. We can see your slides as well.
You can see my slides. I'm just having a few problems here. I'm sorry, I don't know why. There we go. Can you can hear me and you can see my slides?
Perfect. All good.
Yeah.
All right. So thank you. Okay. So I have a bit of problems with my internet connection, and if I break away, I'm sure you won't be missing much. But thanks for starting this new Indian society. I think India is really ready to get everybody on the same society as such a big country with so many different. But I congratulate you on now. From us, we are a true international society, and we are. I look at the past presidents, and I always feel very humbled that there's all the icons of sports medicine, arthroscopy as part of this society. But I'm not going to go into much specifics on what we do, because I think even SKICON is now, we are always trying to reinvent ourselves. We are always trying to stay topical. And it is difficult. What is a society? What is our job? And sometimes we have to be careful to get so proud of ourselves and run it as a business. And I'll talk about that later, but I do not think a society is a business. So first, I think the SKICON mission statements is the advance the world exchange and dissemination of, of education, research, and patient care. So those are the 3: education, research, and patient care in arthroscopy, knee surgery, and orthopedic sports medicine. Okay. So I think it was, it's important to see how SKICON was formed. And it was a merger of the International Arthroscopy Association and the International Society of Knee Surgery in 1995. So we're also quite a young society, not 25, 26 years old. And they combined in the conference in Hong Kong. But I went back to that because I sometimes think, and if you look at the Arthroscopy Association, I mean, a lot of these societies or associations started when arthroscopy came. It was a new technique, and we were learning from each other, and everybody was involved, and we really got, a lot of people got involved, and they learned about, they visited each other, and I think that's how societies become really, really prominent. The knee society was young, they were learning how to do knee replacements, and I sometimes feel now that what do we do? Do we just teach what our leaders feel is important, or do we really stimulate our members? And I think it's something that we have to work with in future, and we really have to answer that question. And I'm not sure, I would like to hear what other people say, but I'm not sure we have the complete answer for all of that. So we work with regional and national societies who share a similar goal to us. And obviously you guys do, providing larger area where these national societies and continental organizations can combine. So we do work with national societies, but we always go to the regional society through the regional society. We're not in the business of making deals with national societies and getting our members as high as possible. I think we will always recognize our regional societies, and I think to have good relationship with everybody, I think is very important. And at the end of the day, the good relationships is with the surgeons that work there, and I think that's important. But I think if we really break down what we do, is we have to educate, and we have to educate our members. And I think the questions that we have to answer is, do we educate them in all of orthopedic and sports medicine research, surgery, or do we really educate them in newer trends? I heard what people had said earlier on, that it's becoming expensive, and the trade is very part of this now. But I think it's something that we have to be a little bit careful about. I think the trade is getting very much into this field of education, but I'm not always sure that they teach the right way. They teach techniques, and young surgeons want to know techniques, but I'm not sure they always understand what they're doing. So I think it's something that we have to look out for, and Zhao mentioned it, that we have to stay independent of the trade. And I think in future, this education is going to be done by us and not by the trade. I think research is always very good as part of our mission statement, but it's difficult. And at ISAKOS have tried many different ways. We sponsored research. We had some big sponsors, multinational, but it was difficult to do. So now we are still trying to find our way. What is the best way to sponsor research? I think one of the good ways for us now is we started our journal, and we really want our members to have a path to really get their research published and to show them how to research. I think that's ISAKOS is getting more into that, and less into putting money down for specific research. So I think it's still evolving. We don't really know what our role is research, but I think we're more into teaching people how to do research, and once they've done research, to get their message out to the world. I think patient care is always important. We want to know that everything we teach and that our surgeons are looking at the patient at the end of the day is the most important. But I think ISAKOS is a little bit different from regional and especially national societies. I think national societies sometimes have a political edge to it, because in different countries, how things are paid for, how things are put forward. I think the national societies will probably be more involved. That's not really an international society like ISAKOS' jobs, but patient care is always very important to us. And I'm just going to leave this, and it's something that I don't know all the answers, but I think that we all struggle a little bit with. I mean, we are not a business, and I think sometimes even us, is when we are so passionate to do the best for ISAKOS, and when we meet, our success is how much money we have in the bank, and how many members we have, and how many big conferences we have, and how efficient we have. And I wonder always if I know all of that is important, but at the end of the day, we are still here to serve our members. And we have done a big drive. We have a new office. So we've really done a lot of surveys to see what our members really want. And I congratulate SKI, because I see that's what you did too. What does our members really want to do? And a lot of them is is meetings. They really want to meet with people. They want to meet with the leaders. They want to be in meetings, and I think that's important. So a lot of these others, the books and everything is important. But if I can give you one good pearl, I think, is to always know that we are here to serve our members, and that we are not an entity on ourselves. So we are always working with this. I think we can learn from each other, but it's evolving. And now with COVID, the virtual side and what it is. But I think we always have to try and reinvent ourselves, not think that we're a business and see how much money we have in the bank, but see how happy our members are. So thank you very much for the invitation. I hope to see you in Cape Town next year. I will be hosting you for the SKICON meeting, and I would looking forward to the discussion. Thank you.
Thank you very much, William, for that honest and heartfelt talk. Just a quick question while the next speaker's talk is being loaded. Unfortunately, Professor Manuel Mascara is not with us, so we'll just be playing his video. So while the technical team loads their video, one quick question for you. There's obviously a dichotomy. You want to be successful as an organization, and you're not going to be able to achieve its objectives unless and until you've got some money in the bank. So how do you balance that? At the same time,
some guidelines.
We don't want to be seen as a business.
Yeah, I think you have to be. The guidelines are you're probably two sections, and we are lucky at SKICON that the guys before me. So ours is a 2-year circle. So they say you must be able to survive 4 years of getting no money in. So, and I think we did that. We are financially prudent, and Zhao is our treasurer. So I think we're in a good financial situation. But sometimes I think, are we too successful? When do you start spending money? I think it's not an easy question. I think I don't really know the answers, but I can tell you, you're right. It's a dichotomy. We want to keep money in the bank, but we also want to spend money to educate our members. I'm not sure I have all the answers, but there are some guidelines.
Good evening, everybody. Thank you to SKICON to invite me to do this presentation. This is my conflict of interest. What is SLAR? What about us? SLAR is a Latin American arthroscopic knee and sport medicine society. It was founded in 1997, initially with just 5 countries. Right now, we have members from almost all Latin countries. We have 20 countries and Spain. We include now almost all joints, not just knee and shoulder. We include ankle, elbow, hip, and wrist also. We are, as you see in the map, in almost all the Latin American countries except Suriname and some islands of the Caribbean. We are right now with 4,674 members, including in that 21 countries. We have many partner societies from Latin America and from other continental. What about our opportunities to our members as knee society? Are in 3 fields: academics, publication and research, and podium presentations. Academic, mainly doing presential activities before the pandemic. We have in the next year, as you see in the screen, the first Latin American meeting. That's mean a regional Latin American SLAR meeting that will be held in Panama. We have also International Congress biannual. We do almost all year cadaver lab, and we have an excellent program with travel and fellowship that we can talk later. Talking about academic presential activities, we start with this extraordinary meeting that we will have to have in September in Panama. One of the things that I want to show you is that we are going to finish at that time 5 consensus. These 5 consensus start 2 months ago with almost many of our SLAR members trying to join young guys, experienced guys, to define this consensus. Massive irreparable calf tears, extra-articular reconstruction in primary ACL, arthritis in unicompartmental, first episode of traumatic glenohumeral dislocation, and lastly, osteochondral knee lesion. We have also an excellent program since 10 years ago. We call Traveling Fellowship. So we do this program with the Continental Association as AOSSM, that you can see the picture. They came to us in 2017. We sent fellows 2 years later. We had 2 years ago also a traveling fellowship with APCAS. They came to Latin America, and we had also SCA fellow travelship. And the last year, before ISACOS meeting in Cancun, we received fellows from ISACOS. Because the pandemic pushed to everyone to increase our activities by media, we developed many activities. For instance, webinar, we developed webinar with the SLAR, with other continental. We almost did 15 webinars between our members. We had, since 5 years ago, online courses. We organized roundtable and case presentation. We did a virtual meeting, and we be a part of a virtual international congress. As you see, we had a year very, very tight doing this kind of activity by online. In terms of publication and researches, our SLAR Society has a journal. It's called Arthroscopia. Right now, we have 4 issues by year. We have also the opportunity to get journal to the other society as Orthopaedic Journal of Sport Medicine, the Journal of Spain Arthroscopic Association, the Journal of ISACOS. All these journals are available for all our members. We start a program, a new program is ESLAR, is like a newsletter. We started 3 months ago. We try to share our experience. We show technical videos, case presentation, and more. And finally, we can offer our members the opportunity to be a lecturer, a speaker, and in different meetings. For instance, in our last meeting in Chile, we have many presentations of SLAR members, special young guys, as you see in the screen. So, what are the take-home values? First, our society SLAR offers great opportunity to our members in different topics, especially in continuing medical education through webinars, online courses, online meetings, traveling fellowships, regional and international congress, and cadaver lab. And last, Arthroscopic and Knee Society are an extraordinary institutions to serve as a bridge between knowledge and our members. Thank you so much for the opportunity.
Thanks to the tech team for playing that talk. Our next speaker is Professor Andrew Price from Oxford. He is the current president of the British Association of Knee Surgery. Andrew, good afternoon.
Good afternoon, guys. Can you hear me?
Loud and clear.
Yes.
Okay. Thank you so much for this kind invitation from SKI, and I'm very excited for you guys in your whole vision in terms of what you're trying to do. I'm talking on behalf of the British Association for Surgery of the Knee. So BASC. I've been president for the last 2 years. And I'm now, Andrew Porteous is our new president, so I'm immediate past president. What's very interesting, and I'm very struck by, is the interconnection that we all have. So we've heard fantastic talks from EKS, ESCA, ISICOS, DARD, all of these organizations. I think we have the same goals. And in fact, we interact very much within this sort of international world that we live in, the global world we live in. It's amazing how much we're already interacting. The BASC has been in place for about 35 years. There are 600 members. We represent the knee surgeons within the United Kingdom. We are under the umbrella organisation of the British Orthopaedic Association. And we also facilitate strong links with the other societies that we've heard mentioned today. We've been struck by COVID this year, so our activities have been reduced. But this year, we were to have our annual spring meeting in Oxford, and that was a combined meeting with the knee societies of Australia, New Zealand, and South Africa. So that's a really, what would have been a fantastic example of how we work across boundaries with the shared principles. And I think our view would be, the top line view is that our responsibility is to our members, and our responsibility to them is to allow them to be able to practice care and put the patient at the center of everything we do. So we're trying to improve patient care, but we're doing that through our members. And that's a very important distinction. Our own situation in the UK is that we have quite a lot to do with creating professional standards within the NHS and across knee surgery in how that is provided for our patients, and also in the private sector. But we're very focused on standards. That leads us to consensus and building patient guidelines. And we're involved with all sorts of national organisations to be able to do that. The National Joint Registry, National Institute for Clinical Excellence, the national audits that exist, including patient-reported outcomes, together with working with NHS and NHS Digital in how we provide care in 2021, as we look forward to the kind of post-COVID era, I hope, with the new vaccination programs that we see around the world. But this, I don't think we're going to go back to how things were, so we do have to consider that. So we have just to give you a sort of a slight insight to how we organize our the way we do things. We have a rolling 5-year program of sort of aims, which are based around engagement with important bodies, both locally and internationally, the production of guidelines and interaction with organizations which are producing guidelines. A good example of that is the ongoing piece of work we have with the European Knee Society, as Fabio has already mentioned, around partial knee replacement, revision, and patellofemoral joint problems. We then see ourselves very much a central role we have is in education. So how do we take those guidelines that we're involved in setting, and how do we distribute that amongst not only the younger surgeons who are growing up, but how do we disseminate changing practice amongst our membership, so that they feel they have a voice and they're able to participate in the learning of how some of this new evidence is taken up. And then we have research, and it's interesting to hear all of the organizations, I think, would probably sounds like we have some of the same challenges, in so much as research sponsored by the organization is quite difficult when you're trying to manage a budget. and large research projects cost a lot of money. So I'm a clinical academic at the University of Oxford, and I'm used to putting in bids for money to do significant research. But there are vast amounts of money to do some of these really big studies. So BASC has had to, I think, modify its approach to how we interact with research. So we want to be right at the forefront of setting the research agenda. So we've done a series of patient-focused programs of setting research priorities. And then we take those research priorities and say, this is what the profession, this is what the members and our patients want us to understand. And we take that to the funding bodies. We take that to NIHR, so the National Institute of Health Research in the UK. And we take that to within Europe, where funding's available. And we really position ourselves as a leader in research in terms of defining what the research agenda is. Then interact with those research projects so we can be very central to the dissemination of that type of information. So I think within those arenas, I think probably our single biggest remit is the production of international or the production of patient-centered standards of care, particularly in the evolving world that we all understand, where technology is moving quickly. Some of that is fantastic, but we also need to be patient-focused to understand that the value is to our patients and not always seeing that from a commercial eye. Those two things need to be seen eye to eye. And I would certainly agree with Wilhelm's point about how that judgment is important to make. The other thing I would say is that we get back from our members, they would state the importance of what the society offers to them in terms of bringing people together. So meetings, we've had to move to a kind of a virtual environment, as we all have done. And I think everybody has done amazingly well in terms of that transition. But our membership wants us to be connecting them, to be talking to us and sharing information. And probably that's what I took home as BASC president as we went into the COVID sort of environment, was people wanted to be connected, to know information quickly, to share guidelines and to share their experiences in forums that they could trust. So that is something that we really wanted to take forward. I would also, just as a kind of shout out for all of the people I know, I know everybody on the call today speaking, and I know all of the members, a lot of the members of their societies at the committee level who are driving this. And I would really say a shout out to them for trying to find people who want to drive change, for their time, commitment to represent the membership. And there are some amazing people out there in knee surgery who we can really, if we give people the remit to be able to go forward and do this, there are some amazing people in these societies. We found that in BASC, and I found that across all of the others. So I'm sure it'll be the same for SKI, and I wish you well in that endeavor because it's very exciting. So thank you very much for the opportunity to speak on behalf of BASC. I'm very happy to take part in this. I'm excited by the conversation.
Thank you very much, Andrew, for that overview on BASC. We'll straight on move to Professor Ashok Rajgopal, who's the current president of SKI, to share his thoughts with us. And then we'll move on to the roundtable discussion. Thanks, Ashok.
Thank you, Vikas and Mohit. At the outset, let me thank all the speakers who preceded me, Professor Mendes, Professor Fabio Catani, Professor Vandermeer, Professor Mosquera, Professor Andrew Price. My good friend Mike Kelly expressed his regrets not being able to make this meeting because he had to be called out to the hospital, and he's actually in the hospital as we speak because of a sort of a slurge of COVID patients. So he sends his regrets. It's indeed an honor and a privilege to have hosted all of you, and we've heard with considerable interest the deliberations that you have put across and put forth. And I think, let me start by saying that we are probably the baby in the cradle at the moment. We are all of about 18 months old, out of which 10 and a half or 11 months have gone across because of this pandemic. So we're all of almost about 7.5 months old. But just to go back historically, between June of 2019, when these group of 26 surgeons interested in knee pathology and knee issues got together, and we considered putting this organization together. And I must sort of pay compliments to Parag and to his team and to every member of the founding members to have put their weight behind the formation of this organization. And as I said, the fundamental issue with any organization is to address the various issues of the specialty. And when it comes to knees, I remember when I started off with doing knees, it was either arthroscopy or joint replacements, and people took their position as either being arthroscopists or being joint replacement surgeons. I think that has undergone a sea change, and today we have a lot more variation, and there is a considerable interest in the science of dealing with knee pathologies as a whole. And I think that has been addressed very eloquently by the previous speakers, and indeed in the 4 days of deliberations that we've had so far. I'd like to acknowledge all our founder members, Sachin, who's a very dynamic secretary. Parag, as I mentioned, has been putting his real weight behind this. Raju as our treasurer, Ashok, Sham, and Dinshaw as our research chairs, and other very young, energetic founder members in Ashish, Adarsh, Alankar, Bhushan, Clement, Joseph, Deepak Goel, IPS Oberoi, Jacob, Kanchan, Mandeep Dhillon. We've been blessed and privileged to have the support of Mohit Bandari, Mukesh Lada, Pankaj Valecha, Pushpinder Bajaj, Raja Bhaskar, Sharon Patil, my good friend Vijay Bose, Vijay Shetty, and Vikas, whose insightful comments we tap into from time to time, and Vikas Kapoor. So as you've heard in the past almost about 45 to 50 minutes, the aim of this very nascent organization is really to conduct training programs and interactive meetings. We hope to research, to engage in research activities and come out with white papers on a number of subjects. There were a couple of multi-center trials that were on the anvil but got held up because of the pandemic. But we are reasonably confident that as soon as this blows over, I think we're going to get back on track. I think it's important for an organization such as SKI, or indeed any of the previously stated organizations, to be able to come out with a consensus document. There is a lot of variability in various aspects of knee surgery. I mean, just to give you an example, the issues of VD prophylaxis, and I was hearing with interest one of the earlier societies talking about VD prophylaxis. I mean, what do you do for instance, with ACL surgery? What is the standard of care with knee replacements? Does aspirin work across boards? And I think some such consensus document coming out of these various organizations would go a long way towards furthering the cause and the interest in knee surgery. The other point which I believe is going to be critical for our credibility is if we can contribute to existing joint registries. And I cannot overemphasize our belief that joint registries form the crux of the validation of outcomes. And a case in example, the Australian registry or the British registry, the Finnish registry, I think these registries have been absolutely instrumental in not only predicting outcomes, but even adverse outcomes with some of the implants, and thereby saving a lot of patients a lot of agony. So we are confident, we are very hopeful that in the weeks and months to come, we will start off on these multicentric trials. And as Andrew just mentioned, we hope that in time we will be able to engage in clinical meetings with the collaboration with the other organizations and actually take this to the next level. And case in question therein was the conduction of this first virtual meeting, which has been, certainly to my way of thinking, a resounding success with absolutely wonderful talks, deliberations, and participation from across the country and the region. We've been very, very blessed, and I must take this opportunity to acknowledge the considerable contribution from our international faculty towards this first SKICON meeting, as you see on this slide. And in particular, patients participants across various timelines and time zones. David Praker, for instance, staying up till 11:30 at night to be in connect with us. We acknowledge with gratitude the considerable contribution from each one of you. So our heartfelt thanks on behalf of the entire founders and participants for your involvement. These were a couple of the subjects that we were looking at: sleep pattern disturbance in patients after TK and its effect on functional outcomes. So we started the validation process, but we have actually not gotten off the ground. We are hoping that in the next few months, we're going to reactivate this. And hopefully by the time we come up to our next SKICON, we'll be well underway to having completed, or at least part completed, this study. The other study that we were looking at was the intraoperative anthropometric knee measurement studies, because there is no question about it. The Caucasian knee and the Asian knee is different, and we just wanted to define the morphological data for the Indian population and people in this part of the world, the subcontinent, and to see the asymmetry between the tibial and the femoral cut surfaces in the Indian population, and hopefully try and come out with an algorithm and in terms of the aspect ratio, and to try and correlate this with the set of documents and available reference points that we have with patients in other regions. With that, I'd like to thank you for your attention, and I'd like to thank all the participants, and I'll hand it back to back to you, Mo and Vikas.
Many thanks, Ashok. Mo, I'll let you kick off with the first question.
Sure. So I've been listening very avidly, and let me, if I could, just raise a question. And we have about roughly 30 minutes to my calculation for a fairly, hopefully, in-depth discussion to uncover some more details from the presidents. But I'd also encourage those of you who are also on the panel, who I see muted and off video, also to join in and share your insights. I think we can make this a fairly collaborative discussion. But let me, I guess, to you, Vikas, first sort of share what I heard from all of these speakers. The first is, there is no shortage of societies around the world. There is no shortage of alliance, or at least convergence of principles. I think the majority of the speakers quite nicely illustrated one thing to me, which is we all have a general idea of what a society should be for the most part, and we want to have the same guiding principles. I guess my question is twofold, and I'd love to hear from others who wish to share their thoughts on this primary issue. SKI is beginning a journey. It's very early. But there are two things that really, I think, struck me as areas where we could really get guidance as a group. And this may be a good opportunity to talk about that. The first is, should we be focusing, for example, should SKI determine its own focus, an area where one might argue doing a few things very, very well may actually serve the overall global network of societies? That's one. And the second thing is, what things genuinely will benefit from global interaction versus having more societies that are much more regionally focused? And I think those are the two big overriding issues I think that I'd love to get some insights on. And I wonder maybe, Vikas, if I can maybe get you to start. I know you're thoughtful on this, and then please, we'll engage as many of our speakers and panelists as possible. But the first question is, how important is focus? Doing a few things very well over doing many things, which also, we only have so much bandwidth. How do we determine how to use it best?
Thanks, Mo. I think you probably know my answers on both of those questions because we've deliberated on this outside this panel a number of times. And the simple answer is I certainly believe in doing few things extremely well and taking them right through. And secondly, in terms of your second question, this is the ideal platform for a global collaboration on sorting out one or two specific aspects, setting up international trials to be able to do that. So those, in short, would be my answers for that, and pretty much elaborated the same in my talk as the vision for SKI and how should we be going along this, both in terms of education and research. But it'll be nice to get views from Ashok as well as the current president. What does he think? And probably start off with him and then move along across the presidents.
Yeah, thanks, Vikas, and thanks, Mohit. I think that those are two very insightful questions to kick off this debate. Let me take a case in question. We talk about VT prophylaxis. That is one of the absolutely gray zones. I mean, your slice still somewhat well-defined when you look at knee arthroplasties. When we look at arthroscopies as a generic group, the role of VT prophylaxis is all over the place. And I think it would be nice for this group, SKI, and then in collaboration with the more established organizations, to do some sort of a consensus meeting or a consensus thought process, a consensus document, to actually come out with the guidelines. Because, you hear so often that in the Asian subcontinent, in the Indian population, VT is really quite rare. Is that in fact the case? I mean, what are the documents? What are the literature saying? What is the actual incidence of VT? Should they be treated? If so, how long should they be treated? I think there is a whole ambit of stuff that we can actually be looking at. I agree with what Vikas mentioned, that I think rather than taking up 5, 7, 8 different topics, I think we need to cherry pick 2 or 3 burning issues that affect the Indian population, but are also relatively unanswered and unaddressed in the other societies, and try and work in collaboration, try and get some sort of a direction or traction in that area. The other thing, of course, is because of the sheer variability in when you talk about just knee surgery, I mean, there's such an ambit of preservation, unicompartments, biologics, arthroscopy, sports medicine. I think if we can cherry pick 2 or 3 subjects, maybe which have a common theme, and then drive it all the way to its logical conclusion, I think we would have started off really, really well. And I think that's where interaction with some of these more established knee societies would go a long way towards defining that fundamental first step that we take, which should be impactful.
That's great, Ashok. Andrew, I wonder if I could ask you this question. I mean, even on a broader level. So what Ashok presented was, how we might narrow down areas of focus, maybe within a research question or maybe within an area, of topicality. But even at the broadest level, do all associations or societies need to be all things to all members? In other words, is there any value in saying, no, maybe we will just focus and be very narrow in our focus, but we will do it with the goal of being leaders that can really inform global issues, and whether it's an educator group or whether it's a research group, whether it's advocacy, I don't know, but there seems to be many hats that many societies wear.
Yeah, I think this is a really interesting point. So I think what this comes down to is the idea that there are many of us all thinking the same questions, and the potential for duplication is enormous. And so sharing information between societies and focusing for an individual society on a couple of issues, and to be able to kind of drill down on that, I think there are real opportunities. And I would say to new societies that I've only had positive responses from other societies when we've tried to work together. So I think people are very open to this. So for instance, BASC, we're fortunate in the UK that we have an established process. We have the National Institute for Clinical Excellence, which creates guidelines as independent. It's an independent group of people who works with knee surgeons, the BASC, BOA, these sorts of organizations. So we've just actually published guidelines on joint replacement for the first time ever in the United Kingdom. Now that is a document would be really useful to share with other societies, so that they can reflect on that. So I think to your point, I think you need to address in your constitution, as it were, all of the issues, at least to be aware of the issues that are important to your members, but you can't solve them all, or you can't necessarily have big programs of work on it at each level. And where you can have an economy of scale working with other societies. And so, for instance, the idea of around thromboprophylaxis, I think, is a really excellent idea, because I know that Fabio mentioned in EKS is looking at that, and I know ESCA has had thoughts on that. So there's a really good example where you could draw things together. So my advice would be aware of the breadth of what's required, and be prepared to respond if you need to within your own country with your members if things are requested. But actually, overall, you can be much more focused and probably more useful in delivering an end product, but work with the other societies, bring people together. I think that this word globalization is bandied around, but here we are on a call, an example of globalization. We can talk like this and share our views. We can do that in more detailed subject areas.
Well, that's wonderful. Thank you for that insight. Because I don't know if you wanted to ask something. I have one other just quick follow-up. Yeah.
Just a comment really more on that and Andrew's response. Obviously, you as an individual or as an executive committee may have this view of delivering something fairly narrow and actually focusing on a global issue or an important problem which needs to be sorted. But eventually, that society depends on what the members really want. It is on what the members' needs are. So there's the dichotomy. You may be sitting on panels and forums like this and may want to do big things and important things, but your membership may not want that. So that's the other thing to think about, or convince your members to be able to think along the same way as well.
And when you think about where you're going to focus and how we're going to go global for any society, there are two statements that were made that struck me. The first one was Willems, who said, "I don't think a society is a business." But our first speaker, João Mendes, said, "No office, no staff, no money." Those are really challenging, statements to make, because the point is, if we want to serve our members and their views, in some ways, we have to find a way to be able to create value for them in a way that may, unfortunately, represent a business of sorts. But I do think the ideals get switched. And I wonder, maybe, João, if you could speak a little bit, Dr. Mendes, if you could speak a little bit to the issue of how do you go from the idea to a flourishing program? And, I think you said something that for you it was, or the journal, having the journal was something very important. Or what was the initial inflection point that allowed, sort of the early beginnings of a society to start getting traction?
A scientific society always has this challenge to balance between stable financial situation and at the same time not to be only focused on that, but be more focused on education. What is my experience on the last 25 years is that you need to be a society that can survive to a pandemic, to a volcano issue that we have in Esca or something like that. And you need to have the money to rule the society. But you should not make a change on your movement because of the money. You need to have a goal. You need to have a goal. You need to have a mission, and you need to pursue and to follow this goal. And what I think it's important is a lot of new societies. It doesn't matter that we have a lot of new societies. They can have their space, they can have their mission, but what they should not do is to overlap other societies that already are doing the same. Because with that, you sold out all the financial sponsorship that you can have. You are going to have a conflict, what is not nice to have a conflict. Why to have a conflict? And many times we see that. So I think as Guy mentioned, it's very important to have a goal. And like Vikas mentioned also, to fine tune every year, every moment with the members. Because sometimes you start with one mission and at the end of the day, the members doesn't want you to follow that path and you need to change. But never be a slave of the money on a scientific society, because the beauty of a scientific society is to have the freedom to do it from your heart without any strong compromise with industry or other concerns.
Thank you very much. I'd like to get your input on this. Yeah.
May I say something?
Yes, please go ahead.
No, I think that, money is important. Business is important, because if you have a mission statements, you need to pursue them. And so you need to fulfill your mission statement. And so you need a good budget. But as has been mentioned very nicely, you cannot be driven by the money. And so your mission statements are your guidance and are your mission, as has been stated. And so I think this is a key issue. And globally, I think globally, this is why I underline so much the consensus work that is so important, because it's evidence based, and so I think that all the society should work together eventually to make some consensus statement on important issue like unicompartmental, totally bicompartmental, and so ever. But the business of the health system is making some differences. For example, in the state, for a unicompartmental arthroplasty, the indication of unicompartmental arthroplasty for the business point of view is better to do a total knee arthroplasty. Or now is becoming so important ASC, the ambulatory surgery. And this is changing a lot of rules. Yeah, because it's business driven. And so for the society, is so important also to look at what the reality is asking us, and the surgeons are the reality, because they are living in the public or in private hospitals. And so it's important to give rules. In the same time, that rules can be changed in the environment. And so this why differences in the societies are important, because are facing different countries, needs, business and health.
Yeah, I mean, the way I take it is, I think I have the screen frozen here, but just while he comes back on, the one issue I would say is, Fabio is raising a critically important point, right? There are going to be areas where we can globally work together, and where some group or some groups can come together and hopefully identify a critically important problem, fundraise against that problem, obviously because it's an important issue, and go forward. But it does raise the other issue, right? About, I believe what Joao just said, right? Which is, we can't have many societies all fighting for the same issues, because then we're fighting and we're arguing. I don't say arguing, but we're going after the same relatively limited resource there is. And I guess I get back to that fundamental question. And I know that, Willem, that you might have had a comment on this issue about a society is not a business. And I wonder if you just want to possibly just share a few thoughts before we continue continue the discussion. But we've got to figure out a strategy where everybody can have a meaningful place in this large ecosystem that is the societies of the world.
Yes, thank you, Mohit. No, I think we're learning as we go along. I think we all as surgeons know, just when we really think we know how something works, we really discover that we didn't really know at all what's going on. So I think we mustn't be too, but this is great conversation. What I meant by a business, I think we should have business principles. We should run our societies through very strict business principles. That I think I'm very happy with. But to me, and I see, to be a business, they can say what they want to all these companies. They want to look at patients. They want to look at everything. But at the end of the day, they want to make money. We all want to make money, and that's fine. But I think as long as we say where we are. So my comment was that we should have very strict business principles, but we should, as Andrew also said, say one thing about the consensus around the world. I see in ISACOS, sorry, I might be breaking up. I think in ISACOS, what's so great for us is that we can see a globe from different parts of the world that things are done differently. People want different things. Their needs are different. So I think we have to be very careful to have a global want more from something. And so for ISACOS, we see it as to recognize that we come from different parts and to acknowledge that different things are more important. And the diversity for me, I think is great. And I don't think we all have to all do the same thing. I think the one thing that we've also started, and we haven't really said about now, is we live in this world and we've started a diversity group. I think females in our group, we all know, is not enough represented, and we have really gone strong to help get more female members, and I think it's going to be good for our societies, and I think all of us should look at that too. So diversity is good, but I think it's acknowledging diversity and realize that we're the same. So that's what I would like to say about. I would be a little bit to have the same consensus everywhere in the world. I think that's going to be dangerous, but we have to respect how we different do it and understand why different people do it differently. I think that might be more interesting.
Well,
Mohit.
Yes, please.
Yeah, so I'm Dr. Maheshwari from New Delhi. I have 30 years plus experience in knee surgery. And I think, first of all, a great job done by our team, our good people, Ashok and company. There are 2 points or 3 points I want to make very quickly. One is India has a very peculiar position because it's another world. Half the world in medicine is something like India. And there's another half which is something like West. And so SKI has a very important role to create that path for almost half the world, what suits them, what is good for them. And we cannot just be going very, very kind of, we can't be a rubber stamp of what's happening all over the world because we are a different people, we are a different country. As Ashok mentioned, a lot of things have to be individualized. And then also India is not Delhi, Mumbai and Calcutta. We have a huge country, their needs are very different, their expertise is very different. And knee surgery is not the domain of only knee surgeons. Almost every orthopedic surgeon does knee surgery. So SKI has a very important role to fine-tune treatment methodology, to give it to not only knee members, almost everybody in orthopedics how they should do things. And for example, evidence on multi-ligament knee replacement coming from a top-class US university by the top-class surgeon cannot be applicable to India or an average Indian surgeon or even an average knee surgeon. So everything has to be repackaged to the need of a different world altogether. And that becomes a leader, at least in the practice of knee surgery in different world. So I think that's a very important focus. We should not be just another organization and does everything exactly the way other people are doing. So I think our focus has to be more based on our own needs, our own surgeons, our own situation, financial, skill development and things like that. And that's the comment I wanted to make in perspective of SKI particularly. Thank you.
Sure. I think, Andrew, you had a comment, and then Vikas, I think you've...
Yeah, no, I'm just listening to this. It's a fantastic debate. And I suppose I'm just trying to crystallize, because I think a lot of things are said, kind of say from my perspective and say Basque. So I think we would all understand the regional and local responsibilities within countries and with even areas of countries in terms of the delivery of care. I think my point about the working together and globalization of this is how you can learn and gather information from these societies. And consensus in the end is consensus. So you don't necessarily all have to agree on everything, and you do things differently, but some principles may come through. So that would be, remember, we absolutely represent the members of the society, and that then means you have a local, say for us, it's within the UK, I'm a member of SKICON, and that has a different role. The last thing is just this issue to pick up, and I think Wilhelm very clearly said this whole thing about the business. What you need is an absolutely sound financial model where you have the finances to do the work you want to do. So in one sense, the best way to look at BASC from my financial point of view, we're actually a charity. We have a charitable status. So we have money coming in and we have money going out, and that's transparent. We're not a profit-motivated organization, but we absolutely have to have a business head to be able to create the money to support and do the things that we want to do for our membership. So again, I think these things are shared by all of us. So it's great to hear the discussion. Thank you.
Thanks, Andrew. And the point I'll add before Vikas jumps in is, even at the level of, let's say, the UK or India, there is no cookie cutter approach to the society's needs, because in every society, Canada included, we have very disparate groups of beliefs of members. And I guess the challenge always is going to be is how do we make sure that we aren't a society that's only working towards one particular group's needs. And that even gets to the larger issue of Willem's, which is, the way to get to a group's needs is to make sure that we represent all, that is orthopedics, including gender, race, ethnicity, age, all those sorts of things. And I think that's a pretty important issue. Vikas, did you want to say something?
Yeah, I'm just going to add both from the experience of British Hip Society and SKICON. In simple terms, no margin, no mission. If you don't have that margin, you're not going to be able to achieve anything. It's as simple as that. If we were able to invest a fair bit of money in the educational e-learning platform, it's just because we had those resources in SKICON to do that. Otherwise, you can't. So that's a simple thing that I've grown up with. That is no margin, no mission. And secondly, I think we should probably tap on all the leaders here to be able to come up with 2 or 3 topics that we really want to research, and then tap organizations like WHO where the money exists to be able to solve global problems. And then there is money there to be able to do this. So you don't have to tap your own organization's resources to do that, but there is money available elsewhere to look at global issues. Even the NIHR has got money for global issues. And a forum like this should be able to actually, a follow-on meeting potentially, be able to solve that.
Friends, we're heading into the last 4 minutes, and you can imagine that I'm sure we could continue to speak. What I'd like for each of our president speakers to do, if they wouldn't mind, is reflect in the next minute or so on one key takeaway that they've had from this discussion. And I suspect we may have the same key takeaways. And while you're thinking about that, and I might ask Vikas to kind of do the roundtable at the end just to get everyone's final comment. The one thing that strikes me about this, and I'll start with my own comment, is that when we think about, let's say, bringing in a new outcome measure, and we do lots of outcomes research, we often say, well, is there a need for this new outcome measure? What will be unique about this new outcome measure? How will we actively test and validate the need for this outcome measure? And we go through this very, very rigorous process in which we are being challenged to say, do we need yet another outcome measure? And I guess the thing that has been particularly striking to me, and I didn't have this belief when we came into this discussion, was maybe we also need to think as a group, what are the unique features that would say, when do we need a new society? And I think SKI represents just that moment, right? Where there is a need, but I don't think I've ever heard it articulated in a way. And I wonder if one of the things we could do globally together is maybe think about a consensus on, when we need a new society and what the role could be and how that might run, more as a principled document that I think could help many others who may be in the future. And maybe the goal would be that we don't need a new society, we need to partner with somebody, or who knows, what that algorithm may look like. Anyways, that's been my sort of takeaway from this, through this wonderful discussion. I thank you all, and I might ask Vikas maybe to lead with a thought, and then maybe, if you don't mind, Vikas, going through the panelists for their final statement. Thank you so much.
Thanks, Mo, on those thoughts. We'll start with Ashok. What are your final thoughts? 1 minute takeaway.
Thanks, Vikas, and thanks, Mo, for that wonderful handling of this panel. My one thought is to look at the unaddressed needs, and there are some common unaddressed needs right across the spectrum of the knee disease management, and to try and come out with an algorithm. I take your point that one size does not fit all, but if we can come out with a consensus which is based on science and evidence and literature review, present that to the audience, to the members, and leave it to their discretion to try and take this forward the best way they know how.
Thanks, Ashok. Andy, we come on to you. Your thoughts?
Yeah, so again, I'm struck by how we all have such common thoughts on how we do this. I think that what I would take away from this is we need to consider about how, as international and then national organizations, we work together and how we can learn from each other. So I think all of these, so the whole idea of consensus, probably what we need to do is to work out how we do that, how we say there are some things that we can have some form of agreement on that allows us to work to not duplicate work and to use the work that other people have used. So I would say there's a real role for trying to bring societies together. And then I think that plays to Mohit's point that you could probably create some sort of overriding statement about what these societies' aims and roles are, and that as a kind of blueprint, because I think that would be a really useful contribution. Thank you.
Thanks, Andrew. Fabio, we come on to you.
Yes, was really a great discussion, and I think that the consensus statement is a key point among the societies. And if you look how the consensus statement or Delphi methodology is made, is on questions. And so questions should be different in different countries and different business situations. And so I agree that there are two main questions that we have as surgeons or scientists. That is the indication of surgery and outcomes. And so we need to make a consensus statement of some of the pathology we are treated. But, I think diversity is the key issue, because SKI or AKS or ACA or American Knee Society, can have different questions about same main questions. And so main topics. And so we should collaborate in this direction. But I think the best now will be indication for the major pathology of the knee joint. And this will help all of us, because sometimes, ideas coming from outside is a richness for us. And so I think that is important to share information among societies. And thank you again for being today. It was great. Thank you.
Thanks, Fabio. Thank you very much. William, we come on to you. Your thoughts?
Sorry, can you hear me now?
Yeah, loud and clear.
Yeah, so I thank you. It was a great meeting, and my one. thought was this: is we need more. As Andrew said, we should. I think the leaders of all these different societies should so many things in common, but I think we get so involved in our own lives on this, is that perhaps as society leaders we should be meeting at more regular and make sure that we take on the different challenges or challenges. But it's been real eye-opener to me how many things we can really solve if we have more collaboration. I think that's, for me, that's really important.
Thank you very much, William. And last but not least, Zhao, your final thoughts and comments.
My final thoughts will be, as a society, be sure that you are serving your members. Be sure that you are raising the level of care of and the quality of life of your patients. Be sure that you don't cross the red line regarding industry, and do it in a fair way, honest way, and do your best for the good.
Thank you very much, Zhao, for that. So what I've heard from all is certainly everybody is looking forward to consensus statements. That certainly seems to be the overriding theme. Everybody wants to collaborate. Everybody doesn't want to duplicate. So that is fantastic as well. And all of us want to honor diversity and do the best for our patients. So those are probably the four most common themes that have actually come out from all the presidents and the speakers out here. So on that, I'll say two things. One is a big thank you to SKI for inviting Mo and me to moderate this. A big thank you, and a big thank you to all the speakers for sharing their thoughts, and most importantly, honest thoughts and heartfelt comments on how we can move forward. And one action point potentially is for the SKI coordinators to organize another meeting between the 8 individuals who are here, so that we could potentially move this to the next stage and actually get something definitely out of it. I think all of us are doers here, and we could certainly achieve something good if we move forward on that. Finally, I take this opportunity to wish all of those who are celebrating a Merry Christmas and a Happy New Year in advance. Hopefully better times to come with the vaccine around the corner. And Mo, over to you for final comments. Thank you.
I think I'll lead with 6 words. Saying isn't doing, doing is doing. And I think we will work together, I hope, with this in mind. And I will now, if I could, conclude the session, thanking you all and returning it all back to the session. Thanks so much.
Thank you very much.
Thank you, and Merry Christmas.
Thanks, guys. Well done. Fantastic session. Thank you.
Thank you.
Thank you. Stay safe. Thank you, my friends.
Ciao a tutti. Thank you very much. Take care.
Bye to everybody around the world. Happy Christmas.
Sure.
Thank you so much, Dr. Vikas and Dr. Mohit, for concluding such a wonderful session. I mean, I have not come across a better example of saying the same things in multiple languages or using a common language for the core values of the society. And now I'd like to hand over the proceedings to Dr. Parag for the pièce de résistance of the evening, the presidential oration by Dr. Ashok Rajgopal. Over to you, Dr.
Thank you very much, Dr. Raju. It was indeed a great session, exhilarating session. Vikas, Mohit, and all the presidents, I thank you, enjoyed every moment of it. It's now my proud privilege to introduce to you none other than Dr. Ashok Rajgopal, who is going to give the presidential oration. He needs no introduction, but being the first SKI presidential oration and being oration, it mandates an introduction. He was born in Pune on September 30th, 1953, and that is the reason why I think Puneites, and particularly me, have a special affinity and liking for him. For those who don't know, he did his MBBS from the famous Armed Force Medical College in Pune, and later went to AIIMS for his post-graduation in orthopedics. And that's where I think he took a liking to Delhi. And after finishing his MCH in Liverpool and FRCS, he started his practice in Delhi in 1985, and the rest is history. He currently is the chairman and head of the Bone and Joint Institute, the Bone and Joint Department at the Medanta Hospital which is like a Medicity itself. Dr. Ashok Rajgopal has performed more than 10,000 arthroscopic surgeries, more than 42,000 knee replacement surgery, and still counting, going very strong. He was the first one to do a bilateral total knee replacement in India way back in 1987. He was also appointed as the honorary surgeon to our Honorable Shankar Dayal Sharma, our president, in 1997. He has been treating a number of sports personalities, but his claim to fame was when he operated on Mr. Pulela Gopichand, our ace Indian badminton player who had a very bad knee injury and which probably many people thought would be the end of his career. But after being successfully operated upon by Dr. Ashok Rajgopal, Gopichand went on in 2 years' time to win the All England Badminton Championship. And that was a big feather, not only in Gopichand's cap, India's cap, but also in Dr. Ashok Rajgopal's cap. He's an avid researcher. He does a lot of academic work. He has publications in many peer-reviewed journals with high impact factors. You know, one of his studies, the midterm results of rotating hinge knee prosthesis in Orthopaedica Belgica, is also published in Journal of Arthroplasty, the various wear patterns in the articular surface. A topic close to his heart is operating upon ankylosed knees, and he does a splendid job at it. I've seen him do it, and he wrote it up in the Journal of Arthroplasty. He has also published in many journals in the knee surgery sports, that are KSSTA. He has also got a publication on bone deficiency in Journal of Knee Surgery, another one on Journal of Arthroplasty, and we can keep counting. But I think the latest publications which deserve a mention are, it's been one of his papers, midterm outcomes of tantalum metal cones for severe bone loss in complex primary revision, TK, has just been accepted in JOA. He has also written up a 5-year comparative functional and clinical evaluation of 2 contrary CR knee implants, which is again just published in the JOA. And the midterm results have now become long-term results of the rotating hinge TK in complex primary and revision cases. So I think there are many more publications, but that's not, will go on, and I'm sure he'll have many more publications. Because of his fantastic work, he has been awarded the highest civilian award in the country, the Padma Shri, in 2014, and also the prestigious BC award in 2014. He was also given the ASI Award of Excellence, which he was kind enough to accept in Pune in 2015, and at the hands of Dr. K.H. Sancheti, and in the presence of Dr. Nandulad. He's been a founder of many societies. He's been a founder member of the Indian Hip and Knee Society and has been its past president. He was also one of the founder members of the Asia Pacific Arthroplasty Society, after which he became the president. And I think he's most happy about being the founder president of the most new society, the Society of Knee Surgeons of India. And its oration, the first presidential oration, is just about to be given by him. I hand over the stage to Dr. Ashok Rajgopal, and we are all very, very keen to hear the presidential oration, which is going to be on my experience of total knee replacement of 30 years, the lessons learned. Professor Ashok Rajgopal, the screen is all yours, and we are very, very eager to learn from you what you learned in 30 years in the next 30 minutes. Over to you.
Thank you, Parag, for that very kind and generous introduction. I'm actually humbled by this position. And in the next 20 odd minutes, 25 minutes, I'm going to talk you through an anecdotal talk on my journey through the past 30 years of doing knee surgery. So the first knee I did as a senior registrar was in England, or at least I scrubbed in, was in 1984 in Liverpool. And this was the duocondylar knee that was in vogue at that point in time. These patients were treated and kept in the hospital for close to about 2 weeks. Results were at best fair. And the available options that I sort of grew up on a diet of was the TCP constrained knee and the geometric and the Liverpool knee, which had at best very average results. We had very minimal exposure at that point in time to the original IB posterior stabilized knee. These were just coming into vogue in England at that point in time, though they were quite popular, gaining in popularity across the Atlantic in New York under the tutelage of John Insel and Chet Ranawat. But my story really begins when I came back to India and I did my first knee on the 25th of April in '87. This was a bilateral knee and it took me close to about 6 hours to do. The interesting part was there was virtually no instrumentation. And we were very, very short on prosthesis options. And we actually had one size of the femoral component, one for the right and one for the left. And we had a choice of one height of the tibia. The implant system that was available to me at that point of time was the Freeman-Samuelson. And the choice of using the implant was in an uncemented mode. Having gotten through that ordeal, the next surgery came up almost 4 months later, and we cut off the time by close to about 1.5 to 2 hours. We had this challenge of using instrumentation, and the few instruments that we had were hard to come by, so we actually sort of, in a sense, copied those instruments. And I had a rather skilled carpenter. We made a sort of mold out of those, and we actually used, believe it or not, for 7 cases, the fundamental instruments that were created by this carpenter. And in terms of being able to sterilize them, we used to do core biopsies of these little teak wood trials and spacers for sterility. The other interesting thing was that the femoral components were not provided to sterile. They came in a openable pouch, which we then had to subsequently autoclave. And we, for want of better reasoning, we autoclaved them twice. And as I said, availability of implants was a real challenge at that point in time. So during the time that we started off, our implant options were the Kinemax, the Miller-Galante 1, and the Freeman-Samuelson. Freeman-Samuelson and the Miller-Galante were CR knees and had cementless options. The Kinemax and IB1 were cruciate excising options, and we did not really have patellar buttons at that point in time, and costs were all pervasive. And interestingly enough, a very perceptive patient, when he asked me about the cost of the implant, and I mentioned that to him, rather tongue-in-cheek, mentioned that it was cheaper to get a new wife than to spend the money on getting her knees done. And in the first 3 years, the knees were few and far between, and we did a total of about 42 knees. And in 1 month, we did 14. And at that point, it was a cause for celebration, not only for me, but for the whole department. When we look at it now, on hindsight, these were our cementless results. MG2, both cementless and cemented, at a 14-year follow-up. And these knees did reasonably well, though you might see on the cemented side, evidence of polyethylene wear on the medial side. So I switched over to the modular uncemented Miller-Galante system, primarily because cement failures at that point in time were common. And the modularity gave me the freedom to balance the gaps. And we also had a challenge for getting cement. So I stayed with the cementless school of thought till almost 1995, and then continued this till 99. When we reviewed our results and our outcomes of these rather primitive cementless situations, our 10-year survivorship of the cementless platform was 97%, and 15 years was 93%. Revisions at that point of time for these cementless options was largely because of poor polyethylene and wear issues and design issues. And consequently, this really established my faith in the cementless philosophy. 3 people who influenced my career in a big way was John Charnley, my mentor, my guru, Graham Hayes, with whom I trained in Liverpool, and John Insel. I had the privilege of scrubbing with the 2 Johns, with John Charnley in 1983 in Brightington, and I had the privilege of scrubbing with John Insel twice in between 1999 and 2000 for a period of 6 to 8 weeks. So, and from these gentlemen, I learned to be uncompromising in principles and exacting in getting the outcomes. From John and Saul, that knee replacement surgery was a soft tissue operation, and guiding principles had to be followed no matter what implant was used. On the last day that I was with him, and as I was leaving him, he asked me, and I had to honestly confess that I was fundamentally a CR surgeon. He did sort of give me his blessings and said it was time I changed over to being a PS. So in the early days when I used to present, CR knees was a taboo and was very frequently challenged by the gurus of the time on the wisdom and veracity of my decision for retaining the cruciate. And the more I was criticized, the more I was determined to walk down this path. And when I did my first presentation in '93 at one of the regional conferences, I was actually my slides were viewed with considerable horror. Typically, these were the kind of knees that we were presented with at that point in time. These were neglected rheumatoids, long-standing degenerative knees. And for want of anything better and my conviction, we stuck to the CR philosophy. And the good thing is that the issue of CR versus PS, which was the fundamental debate topic in the 90s and the early 2000s, has been laid to rest. And it was also traditionally believed at that point in time that CRs were traditionally useful only in knees with minimal deformities. We took the contrary position, and we sort of established in our mind, certainly, and to our patients, that CR is a viable alternative even in very severe deformities, and stood the test of time. And certainly in our experience and that in literature, CR needs and knee function did not deteriorate. And at 15 years, our survivorship was noted at 92 degrees. We wrote up about this in the Acta Orthopaedica, about the evaluation of the PCL in long-standing CR knees, and we noted that it was present and at least functional in a large percentage, including fused knees and rheumatoid knees. And we believe that PCL retention implant preserved bone stock, maintained joint lines, and had the option at that point in time of being able to use the cementless options with very predictable outcomes. So at that point in time, this is a slide that we put together about 6 or 7 years ago, that we believe that CR could be done in most types of deformities. And you can see over here that we had a CR rate of almost about 95%, 96%. And we'd like to take you through some of these options. This is a rheumatoid ankylosed knee, fibrous on one side, bony ankylosis on the other side. And this was treated using a CR knee with good outcomes, a very severe 40 degrees fixed valgus, again treated by a CR option with predictable long-term outcomes, a malunited high tibial osteotomy, again treated with retaining the cruciate. We believed in the philosophy of understanding how to balance the PCL, and we did reasonably well. Now, here is a patient who has very severe varus subluxation. I would concede the point here that most people would go in for some kind of a constraint, maybe as PS or maybe a mid-level constraint in today's configuration. But at that point in time, we chose to retain the cruciate even in these very horrific knees. And these are her X-rays at 14 years, doing well. Extra-articular deformities, again, were something that we used to see quite commonly at that point of time. We don't really see them nearly as bad now. And again, these are outcomes with restoration of the mechanical axis. Hyperextension deformity was yet another sort of challenging pathology. And here again, we managed to get by retaining the cruciate. We did a histological study of these knees, and this shows normal collagen in a lot of these patients. This, in fact, was taken from a patient with a periprosthetic fracture. In fact, this patient, and this is done almost 12 years after the index surgery where we revised the knee. And you can see over here that in spite of the periprosthetic fracture, there's been fairly pristine condition of the PCL, even 12 years after the index surgery. So what did we learn? That the keys to success was perseverance and self-criticism. We recognized that all new factors do the define predictable success. We walked our way through a large part of the developmental products that came about. We got introduced to modularity, having started off with monoblock and all polytibias, and they certainly gave us flexibility, but at that point in time, with the poor designs, opened the need to a new mode of failure, which was osteolysis. And you can see with these, with the screw fixations, that the femoral component caused tremendous amount of osteolysis in the distal femur. In contrast, if you look at the CR longevity outcome, this is one of my first surgeries done in 87, 88. This patient had a 31-year follow-up. In fact, she died soon after these x-rays were taken from a myocardial infarction. And you can see over here that there's virtually no demarcation. The patient had excellent outcome, and you can see this is an unresurfaced patella, and it's holding its position with excellent alignment and no evidence of wear. At that point in time when we started, we were also chastised for doing bilateral procedures. We were among the first in the country to do bilateral procedures. I was actually censured by the administration in my hospital for doing this. But we have now established that this is the methodology of choice, as do many, many surgeons across the country and across the world today. Obviously, we need to discuss the options of the family, choose patients who are medically fit, but they're particularly true in situations where patients present late, as they do in this part of the world, with severe deformities. So our current practice is to do them in patients under the age of 75 who have no comorbidities or not more than 2. And we look at patients with cardiac issues or patients on anticoagulant therapy with caution and care, and do them staged. And all cardiac and hypertensive patients have a concomitant carotid Doppler. So technologies in the last 2 decades, a snapshot, we've gone through MIS, HyFlex, the gender, the navigation, PSIs, robotics, newer materials, better instrumentation, and newer implants. So I've witnessed and sort of walked through this entire generation. We started off with the MIS, and if there's one thing that I would sort of concede, that has been the abject point of disaster with knees and indeed hip surgeries, it's been this 2-incision hip surgery and the MIS, where we've tried to put in this knees through really small incisions. And this has been the one thing that has been an absolute abject disaster. High flex knees are still a debatable, contentious topic, whether it is the design of the implant or the surgical technique or the preoperative function. I'm not going to dwell on this. What I will mention and say is that what technology has achieved, it may not be necessarily greater flexion, but safer flexion with a predictable rollback. And here are some of the absolute disasters. I mean, we went through the phase where we were using carbon impregnated poly inserts. Within 12 months, all these patients came back to us with massive synovitis. All of them needed revisions. And this was very similar to metallosis with absolutely black synovium, synovial hypertrophy, and black sludge fluid. These are examples of MIS surgeries. You can imagine what a struggle it must have been to put in a knee through these really small incisions. But we embraced technology as we went along, and I cannot talk of a better technology than the TM cone, the trabecular metal as a material for various types of indications. Here you can see distal augments and femoral and tibial cones. We use them in situations with patellar loss, bone loss, where there's a shell of bone available, and in difficult revision situations where there was massive bone loss. We also had considerable experience with the monoblock uncemented TM design, and these are 9 months post-operatively with excellent function and bone adherence. In terms of salvage options, these were very challenging cases. This patient had had 8 to 10 previous surgeries with massive bone loss. We used stacked cones. This patient also had a dislocated patella, and we were able to restore the alignment and the function with relocation of the patella using technology. Going beyond the routine, we've had experience of doing these megaprostheses for malignant tumors. And of course, the one thing which has been the talk of these last 4 days, the unicompartment disease. We do a large volume of both medial and lateral unicompartment disease replacements using unicompartment options. So our take really has been, we have embraced newer technology, we've tried them all, but never gave in to be a slave to any of these. We walked through the issue of the PSI, which was the new mantra in 2002, 3, 4. We used this extensively. And the advantages were that it was meant to reproduce the exact measurements and shorten the operative time. It obviated the need for intramedullary guides, and preoperative planning actually took into account the periarticular osteophytes. It improved accuracy and optimized the size options, so you needed less instruments and less trays. And these are the kind of templates that we got from Belgium, and these helped us to orient our treatment methodology and options. So it eliminated a lot of instruments, and both on the tibial and the femoral side, multiple approaches. So we really had very few instruments that we needed to use for the actual execution of the surgery. And this is really what the molds look like. They were pinned in place, and the consensus is over time, this actually sort of fell by the wayside, primarily because there was a conversion of almost 38%, even in the hands of the developers. And the primary reason for that was at that point in time, there was no sort of guide to rotation. And at that point in time, and currently, I think it's a high cost, low output option, but a great marketing tool. Navigation was the buzzword in the late 90s, early 2000s. And while there are still a considerable number of surgeons using it, the incidence has gone down to about 5 to 7%, because it is primarily a computer-assisted, not a computer-directed surgery, though the die-hard advocates of navigation would contest this statement. And there are several literature reviews that pretty much say that the impact on optimized alignment and longevity is unproven, and unexplained pains are often due to rotational malalignment. And PSI has also not been universally accepted due to lack of clarity on rotational alignment and inability to balance soft tissues. We then moved on to the issue of the iAssist, which is a radio frequency technology, which has accelerometers and gyroscopes and temperature sensors. We were with this technology for about 2 to 3 years, and this had certainly some potential benefits. And over time, this also was passed by, primarily because this did not give us a great incentive in terms of improved outcomes. We then looked at the newer materials and the talk about the metal allergies. And at that point in time, the new buzzword was the oxinium, which provided a low coefficient of friction, which is really a kind of ceramic coating on a chromium cobalt base and is scratch proof. And certainly in the lab conditions, they had a potential life cycle of over 40 years. It has given reasonably good midterm results, though the Australian registry has questioned its perceived superiority. This is really what it looks like. It's an anodized ceramic coating, and this is one of the options using the oxinium. The latest new kid on the block has been the Navio or the Mako or the Rosa's robotic options. We've had experience with both the Navio and the Mako, and this is really what your platform looks like. Again, in terms of outcomes, people have questioned whether it necessarily gives you better results, and we certainly would like to submit that early results are encouraging, but longer term follow-up is needed. And I think the most telling comment was mentioned by Bob Booth in JOA 2019, that with the existing 98% at 10 years, 95 at 20 years, current technology must better this figure. And there is certainly no evidence and not enough time for us to be able to validate the statement. The new challenge has been the revision, and you can see a myriad of different modes of failure over here. And treatment options are both available, but they're expensive and the surgical technique is demanding. So what are the tech trends in the 2018? This is something we are hopefully going to get to. Virtual reality, artificial intelligence, and augmented reality. But currently, as we speak, the clinical applications struggle to deliver in this area. 3D printing is the new kid on the block, so this is probably more helpful in the hip scenario, but has also been tried in the uni compartment. And again, when you look at this systematic review, there is undetermined efficacy as we speak today. But these are some of the clinical applications in the context of the hip area. We continued this journey, and I think one of the most defining moments in my professional career was my participation in the development team of the Persona design team, where we had the privilege of working with some of the finest knee surgeons. Here you can see Andrew Freiberg, Mike Kelly, and Jean-Noel Argenson. And it was an enriching experience and a very humbling one. And in 2013 at the AAOS, we launched our book on knee surgery. And we had contributions from these stalwarts, as you see. This is Gil Scuderi, Aaron Rosenberg, Bob Booth, and Doug Dennis. Along the way, we met some wonderful people. We had the privilege of treating them, operating on them. Professor Holz, the Dalai Lama, and this young lady, Zora Sagal, whose knees we operated when she was 98 years old, an absolute darling. So what was my biggest learning? Understanding the basics, being critical of ourselves, and the importance of teamwork. None of what we do can be achieved by doing this on your own. And most importantly, we understood that recognizing failures, especially our own, and how not to ignore them. And why do I say this? This is a case in question, the one that you saw earlier. This was very, very early in our times. We had no trials. We had no great instrumentation, balancing tools, and yet we managed to achieve this 31-year follow-up. And what did we do right? We followed the basic tenets. We balanced the gap, restored the alignments, and the only technology we used was basically sound surgical principles. And the result was a well-functioning knee 30 years after its implantation. This was the contralateral side, again, 31 years. So we had one with a metal back and one with a all poly, and both of these implants were uncemented. So currently, as we see, the real issue is understanding risk factors, and now in 2018 and 19, we can understand this a little better in terms of sarcopenia, the frailty index, which will indicate possible morbidity, mortality, or prosthetic infection, and patient identifiers are the new paradigm for safety. So our present position is we continue to believe in the CR position. We do not resurface the patella in the majority of cases. We believe firmly in the uncemented mode, ideally the monoblock, and we believe the long-term outcomes and survivorship is both surgeon and technique dependent. Our stand is that we use technology as an aid, but we are not slavishly driven to use this regardless. I'd like to thank you for the honor and the privilege of delivering this first SKI oration. Thank you for your kind attention.
Thank you, sir. Thank you so much. That was indeed exhilarating. That was a fantastic presentation. You know, I don't know how to give a standing ovation, but I can do that. You know, and it was fantastic. It's difficult to give a standing ovation virtually, but you deserve more than that, Professor Rajgopal. So a lot of learning. Fantastic. You know, there are no questions to be asked, but after oration, but I can't just resist asking you two questions, and I want more philosophical answers on that. You know, first question, Professor Rajgopal, is that do you see robotics coming in a big way in the future? So once you answer that, I'll ask you the second question, and then we end the oration.
I believe, Parag, that robotics will be a tool that we're going to use increasingly in the future. In its present generation, I think we are still in its infancy. It is gaining in popularity. I think it will become the go-to standard in the years to come. It makes the surgery reproducible. It makes it scientific, and you're able to validate your outcomes. And more importantly, it defines the variables. So I think we're going to get into that sweet spot, and across various platforms and different disease patterns, I think we're going to make this surgery more predictable.
Okay, so I think that's a message. So people should jump onto this wagon soon. I think it's going to be the future. I can also see that. The second question is, you being the first one to do uncemented knee replacement in India, but over a period of time, it kind of went down. But again, we heard Dr. Thakur speak on the first day on uncemented knees. And do you personally feel that it'll come back like, the cemented total hips are completely outdated and everybody is doing uncemented total hips? Will that kind of comparison work in knee replacements? What are your thoughts on that, Professor Rajgopal?
I don't think we will replace the cemented knees, given that the 25-year survivorship is, in the region of the early 90s or late 80s. But I do concede, and I would like to believe and feel that the future of the cementless options, particularly with current materials, is very, very bright. And my final sort of telling comment on that, Parag, would be if ever I needed a knee replacement, it would be cementless. It would be a TM, and I would have no patellar resurfacing. It would be a cruciate retaining and an uncemented knee. That would be my go-to choice.
I think that speaks a lot. That speaks a lot. If you can say this on a platform where probably a few thousand people are watching, it means a lot, and it shows your conviction to the cementless technology. So on that note, I think Professor Rajgopal, we will end this first SKI presidential oration. It was absolutely outstanding. I'm seeing the messages pop up on the chat box. Everybody is absolutely overwhelmed, and a lot of learning. And I think the talk can be good only if the person who gives the talk is doing it, because there are people I've seen who give theoretical talks and it doesn't get that kind of a cutting edge, which we have seen, absolutely coming from the heart, from within. Every sentence, you didn't have to bat an eyelid, didn't have to think twice what you were saying. That shows a lot. So thank you once again. A big round of applause from all our SKI members. I request all of them to be on video. You can put your video on now. There's no problem of the bandwidth. So please, a big round of applause from all those on the screen. Thank you, thank you,
thank you very much, Parag. It's been an honor and I'm very humbled. Thank you so much. God bless.
Excellent, excellent. So we now hand over the proceedings to Dr. Raju Ishwaran, and we have a very interesting program now. Please don't go away. Another 15 minutes, we'll be done. May I request Dr. Raju Ishwaran to please take over the proceedings and anchor the book launch. One of our founder members, Dr. Deepak Goyal, has written a fantastic book, the illustrative book of cartilage repair, and I request Professor Raju Ishwaran to start the proceedings to launch this book through the SKI platform.
Right. So what a exciting talk by Dr. Ashok Rajgopal. On a lighter note, I'm sure he told the patient concerned that it is getting a new wife is far more expensive than one thinks. So the next event is a much anticipated book, the illustrative book on cartilage repair by one of our founder members, Dr. Deepak Goyal, whose work in cartilage needs no introduction. And the very fact that he has used his time in the lockdown and the current pandemic so productively to come up with this wonderful book is kudos to him. And I'll hand over the proceedings. I'll hand over the stage to Dr. Deepak, who will tell us more about this book.
Thank you, Raju. So before I begin, am I audible?
Yes, yes, very much.
So before I begin, I had been told that to speak about the challenges which I faced while producing this book. And if you can see the slides, then I can proudly say that my biggest challenges were my authors, my corresponding authors. And I'm proud of that challenge.
We can't see your
slides are not available. Okay, just a moment.
And, I request Deepak to first make a presentation about his book, the challenges, hurdles, and what all he faced. And then Dr. Dinsha Pardiwala and myself will say a few words on it. So Dr. Deepak, please tell us.
Okay. So is my screen visible now?
Yes.
Okay. So thanks, Parag, for asking me to speak about the challenges. Before that, I'm very much thankful to Dr. Ashok Rajgopal, Parag, and the SKI team to allow the very ethos of our organization, that is to promote research and to promote publications. So the challenges are that I can proudly say that my biggest challenge of producing this book was my corresponding authors. And I'm so proud of this challenge. This is because all these beautiful people that you see on screen are very busy and very big cartilage surgeons in the world. Hundreds of research projects, thousands of papers, and very busy clinical practice. And if you ask them, they have got tens and thousands of clinical pictures of cartilage repair. And when I asked them that give me one complete case series, starting from diagnosis of cartilage lesion, decision-making, step-by-step procedure of a surgical technique, rehabilitation picture, and long-term result, it was like finding a needle in the haystack. It was a difficult job for them, but 2 years of hard work, each of them produced beautiful illustrations. Some of them called the old patients for follow-up and took MRI pictures. 2 of the basic researchers started a new project in their universities and came out with anatomical and histological sections on cadavers. So my profuse thanks to all my corresponding authors who had helped me to produce this wonderful book, which is illustrative book of cartilage repair. And when you go through this book, you will realize that this book is actually a full concept, a comprehensive book of pictures after pictures, talking about basics of anatomy, histology, gross anatomy of healthy joint, of degenerative joint, the MRI diagnosis, the classification, the biomechanics of cartilage repair or biomechanics of cartilage injury, each surgical technique described in detail, be it mesoplasty, marrow-stimulation technique, ORTS, all types of ACI, cells techniques, scaffold techniques, cell-based techniques, cell-free techniques, and allografts. It also talks about 3D bioprinting, which is a futuristic option. So I'm happy to produce a book which itself is a comprehensive book from basics to future. And I hope authors, readers around the world will like it. There's a discount code which has been offered by Springer, and I can send this code later on. No need to write it down because it's a very complicated code. Over to you, Parag.
Thank you. Thank you very much. And congratulations, Dr. Deepak, for this excellent book. The first time I got a glimpse, I'm just waiting when I can put my hands on the real copy when I get in front of me, and I'm sure it'll be very beneficial. I would now request Dr. Dinsha Pardiwala, who is one of the co-authors of this book, to please give his comments about this book. Dr. Dinsha, please.
Thank you, Parag. So first, I must really congratulate Deepak, because writing a book and editing it and something of this magnitude is not a simple task. I think all of us are busy surgeons, and to get down to this difficult task and actually complete it is a great accomplishment. So congratulations, Deepak. I've gone through the book and it's absolutely fantastic. And I think what really stands out amongst all the other books that are there in cartilage repair today is the fact that this is really a pictorial essay on every possible topic in cartilage, right from anatomy to histology, all the different techniques, MRI diagnosis, post-op MRIs of all the different techniques. And a picture says 1,000 words. And this book has, I think, over 1,000 pictures. So anyone who's interested in cartilage repair, I think, would get a complete overview. And I think it's a great way to learn how to do cartilage repair. So as surgeons, we always have our tips and tricks. And this particular book really brings them out so well. Sometimes you read a text and you think this is the way that surgeon does it. But when he gives you stepwise photos of each of the steps that he's using, I think you get a different perspective altogether. So I think it's a great endeavor. I think this is something really new, a concept that I hadn't seen in the past. And I really loved it. So very, very proud of contributing to the book. And Deepak, really great endeavor. I'm sure it's going to be a book that's going to be read for many, many years. Congrats.
Thanks. Thank you.
Thank you. Thank you, Dinsha. I also just want to say a few words. I have not read the book in person, but very soon I will. But I think this is a book which has 778 high quality pictures. And as Dr. Dinsha said, one picture can, tell you what 1,000 words can describe. So you can imagine the amount of knowledge, the wealth of knowledge you will get from this book. It is a must read for all those who are interested in joint preservation, not only in cartilage surgeries, but also joint preservation, because there are some chapters which are written on also orthobiologics, what is the current trend, and how osteotomy can influence cartilage healing. So I think that's fantastic. And Dr. Deepak, congratulations, and thank you for offering us a 20% discount. You can send me the code and we will send it to all SKI members. If you can get a 30% discount for SKI members and 20% discount for Indian orthopedic surgeons, then at least the SKI members have an advantage. And we have now 238 live SKI members, so they will be happy to get that discount. So once again, congratulations and well done. I look forward to receiving the physical copy of the book. So that
Parag, Dr. Bruce Ryder has sent a message for this, if you allow me to play his message.
Okay, sure. We can't hear it, Deepak.
Sorry, can you still hear it?
We can see it, but we can't hear it.
Oh, I don't know how to allow that.
You need to enable computer audio.
Okay, how to do that?
Otherwise, you can just send it to me. I will put it on the group.
While sharing the screen, you'll get an option of also sharing the system sound.
Okay.
Deepak, you try it. Otherwise, you send it to me, and we will just proceed with the program.
All right.
You just try it back end. If it's working, we'll come back again for it. Don't worry.
Okay. All right. So, okay. Yeah, I got it.
So this.
Flex hope for a solution. Repair is the key word here. No, the problem is not completely solved, but just as many different strategies are being pursued to conquer COVID-19, many different strategies are also being pursued to repair the seemingly unrepairable damage to articular cartilage. This book illustrates the hard work and creativity of many researchers and clinicians. In this one volume, Dr. Deepak Goyal and colleagues offer the clinical specialists all the information needed to understand the nature of cartilage lesions, historical and contemporary approaches to their treatment, and a peek into what the future might hold. Dr. Goyal has assembled an outstanding group of experts in the field to provide the reader with the most authoritative information available on each relevant topic. The hallmark of this book is the exhaustive collection of illustrations that augment the text and thoroughly clarify each teaching point. Arthroscopic and gross photographs, photomicrographs, computed tomograms, magnetic resonance images, and original artwork all do their part to bring the text to life. The illustrative book of cartilage repair provides every reader, from novice to expert, with the knowledge needed to navigate this dynamic medical field. Congratulations to Dr. Goyal and his colleagues for producing such a valuable and comprehensive volume.
Thank you.
Thank you. That was excellent. Those words coming from Bruce Ryder, who's himself written so many books, it means a lot. So congratulations, Deepak. All of us look forward to seeing the book in person. So may I request everybody to please put their videos on. We come to the last 10 minutes of the program, and that is the valedictory and the award ceremony. We had awards for 3 papers which were presented on day 1, the arthroplasty, and the day 2 was arthroscopy, and the day 3 was joint preservation. So the best arthroplasty paper award went to Dr. Karthik Chithartha for his work on a long-term cross-sectional study with modified forgotten joint score to assess the perception of artificial joint after total knee arthroplasty. So a round of applause for him. He gets a cash prize of 500. He's not eligible yet for the free ski life membership, but as and when he becomes eligible, you will get it, Dr. Karthik. Dr. Karthik, are you there? I think he's not joined. Okay, so we go to the next award. Hello. Yes, Dr. Karthik. Okay, so the next is for the best arthroscopy paper award by Dr. Pankaj Kumar Sharma. He presented his work on patellar instability, a comparative evaluation of clinical and functional outcome in MPFL reconstruction and soft tissue reefing or soft tissue balancing. So good work. He's the assistant professor at AIIMS Bathinda. And congratulations, Dr. Pankaj Sharma. You get a cash award of 5,000 rupees and a free life membership for ski. Are you there?
Yes, sir. Thank you very much. Am I audible?
Yes.
I am very grateful to all the organizers and my mentors for the giving me this opportunity to present my study. And I am very thankful to my senior colleague, Dr. Ashish Devgan, which is my work with him and under guidance of Dr. Ashish Devgan. And this is very great program of Knee Society of India, the first conference. And I am very thankful to all of us judges and my mentors. And I wish you all the best for the next or the other meetings in the future also. Thank you very much, sir.
Thank you very much, Dr. Pankaj. We now go to the last best award, that is for the joint preservation, goes to Dr. Amit Kumar Yadav for his work in functional outcome of high tibial osteotomy in patients with medial compartment OA using the dynamic axial fixator. Congratulations and well done, Dr. Amit. Are you there, Dr. Amit, with us?
Hello. Yes, sir.
Yes, Dr. Amit.
Thank you very much for allowing me to present. I would like to thank you, my guide, Dr. Mangal Pariyar and Dr. Eknath Pawar. Thank you very much.
Thank you. And before we finish off the 4-day proceedings in the last day today, I would request the executive committee to say a few words. I know Dr. Dinsha is in a hurry, but Dr. Dinsha, please say a few words. You are the research chair, and please share a few words. I know you have another meeting to attend in a few minutes from now. Dr. Dinsha, please.
Thank you, Parag. So I think I really enjoyed this key meeting. Unfortunately, we can't meet face to face, but I think listening to all of our colleagues, all of our seniors, many new members, and a lot of our foreign friends is great. So although the lockdown hopefully is now slowly going to go, and hopefully all the meetings in the future are going to be face to face, I think some of the meetings at least will be net based. And seeing this, I think this is quite encouraging. We can certainly learn, we can certainly interact, and we can certainly contribute towards both research and education via meetings like this. So I think it's a really successful first SKICON. And Parag, I'd like to congratulate you really for all the efforts that you've taken in making sure that this went off so well. So good organization and great execution. Congratulations.
Thank you, Dinsha. It's always a team effort. Before Dr. Raju and our president speak, I want to request the man behind the scene, Dr. Ashok Sham, who's also a research chair, who has been, behind the scenes doing the virtual platform, getting the OrthoTV. And today he'll also tell us how many viewers were there and tell us his experience so far with ski and his vision. Over to Dr. Ashok Sham. Thank you. Thank you. Our two overseas founder members, Dr. Mohit Bhandari and Dr. Vikas, are with us. May I request Mohit Bhandari to please say a few words on the concluding and the valedictory function of SKICON.
Sure. If I could, I would just like to say the following. You know, it's rare to see the amount of enthusiasm that I'm seeing for a group of individuals who are very, very established, but have the same joy of starting something new. And I think that's what separates, I think, many societies, the good ones from the ones that, you know, are unlikely to move forward, which is the sense of passion. And I know it's a cliche, but all I felt today and yesterday have been passion. So congratulations, Parag, the team, the founding members, and all of us behind the scenes, especially every single member, because without the members, we have no movement. So thanks so much.
Thank you very much. A few words from Vikas Khanduja.
Parag, I think all has been said already, and I think Mohit articulated it very nicely. I'll probably just go back to one of the slides that I showed in my talk earlier today. I think the amount of talent that there exists in this group, in all the members, the numbers that are done in India, the IT infrastructure that exists in India, I think you really need to harness on that. And I think the sky is the limit. So brilliant, well done, many congratulations, and lots more to do, and a very bright future.
Thank you, Vikas. May I now request Dr. Raju Ishwaran, our treasurer, to please say a few words and hopefully make our society rich. But as we heard from some of them, we don't want to make it a business. And I got a comment from Dr. Amar Ranawat, actually, and he was saying that in the US, we have to pay $1,500 for AOS, $1,000 for ACAS, and so on and so forth. So I don't think we want to do that, but Dr. Raju Ishwaran, being a treasurer, we would be happy to hear a few words from you.
Thank you so much, Dr. Parag. As far as riches are concerned, all that I can say is that I'm an extremely rich company. And this was a very wonderful experience, really. To be honest, I was a bit skeptical about 4 days, 3 hours every day, how to maintain the audience interest. But then the time just flew by, and the conference ended on a spectacular note. And this encore today, the president's roundtable and insights from our president, they were all so nice to hear. So all I can say is that we will really have a very tough job exceeding the standards that we have set in this particular meeting. And I certainly hope that with the well wishes and blessings of all concerned, we can only move forward. Thank you.
Thank you. So we have 1 minute to go before Dr. Ashok Rajagopal speaks. Any of the founder members would like to say something, just raise up your hands. Otherwise, I will request Professor Ashok Rajagopal to please conclude the 4 days of SKICON. President of SKI, Dr. Ashok Rajagopal, who gave a lovely, lovely oration, and the memories of this oration will linger for a long time. But for now, over to Dr. Ashok Rajagopal to conclude the 4 days and also today's session.
Thank you, Parag. I will sum it up in 3 words: passion, content, and commitment. I think this was seen in abundance. The quality of the deliberations was absolutely top line. It was a very interactive session. Each of the speakers spoke with a lot of passion, with a lot of commitment, and the content of their talks was extraordinary. We can only go from strength to strength, and I wish every member of SKI every success. We'd like to encourage a lot of the participants to enroll, join us, and we hope that with your commitment and your contributions, we are going to be even a better society. Thank you for all your contribution. And Parag, once again, hats off to you, to Ashok Sham and the team for their behind the scene. Ashok Sham has always been the understated hero champion of this whole cause. He does all the miracles without actually taking in the limelight. But hats off to you, to Sachin, the whole group and the whole team. And we look forward to many more such deliberations. Thank you very much and God bless.
Thank you. So we will end on this note. Special thanks to Wama Events for their help to run this event. Special thanks to OrthoTV for all their help, and also to Mr. Anuj from Delhi for the virtual platform. So for now, it's bye-bye, and thanks to all the founder members. And last but not the least, all the delegates who joined us, and also those who are on the OrthoTV platform. Thank you very much. See you soon. Bye-bye. And as all good things should come to an end, so will SKICON. Thank you. Bye-bye.
Thank you, Parag. Thank you. Bye-bye.